purpose of this morning's meeting is to consider the provision of home care services. So on behalf of the committee, I would like to welcome Ms Celine Clark and Ms Audrey Dean of Age Action Ireland, Mr Liam O'Sullivan and Mr Pat McLaughlin and Ms Joan Harty representing Care Alliance Ireland, Mr Joseph Musgrave and Mr Ed Crotty of Home and Community Care Ireland, and Mr John Dunn and Mr Claire Duffy from Family Carers Ireland. Thank you for coming. Just for your information, I wish to draw your attention to the fact that by virtue of Section 17(2)(l) of the Defamation Act 2009, witnesses are protected by absolute privilege in respect to their evidence to this committee. However, if you are directed by the committee to cease giving evidence in relation to a particular matter, and you continue to do so, you are entitled thereafter only to qualified privilege in respect of your evidence. You are directed that only evidence connected with the subject matter of these proceedings is to be given, and you are asked to respect the parliamentary practice to the effect that, where possible, you should not criticise or make charges against any person, persons or entity by name or in such a way as to make him or her identifiable. I also wish to advise you that any opening statements you have made to the committee may be published on the committee's website after this meeting. Members are reminded of the long-standing parliamentary practice to the effect that they should not comment on, criticise or make charges against a person outside of the Houses or an official either by name or in such a way as to make him or her identifiable. Can I now ask the opening statement from Age Action Ireland, Celine Clark? Audrey Dean.
Yeah, thank you, Chairman. Good morning, everybody, Chairperson, Deputies, Senators and colleagues. As the largest representative body for older people in Ireland, Age Action is truly delighted to come before you today to give you a brief overview of home supports, current context, deficits and impact on service users and their families, which is the critical thing. We'll conclude this short presentation with our key requests, which align totally with the Home Care Coalition, and that's a grouping of 22 national organisations which advocate and indeed engage with the Department of Health on this critical area of health and social care policy. We know that the deficits and challenges facing the Irish health system are complex and multifaceted, but from our experience and our direct work with older people and their families across Ireland, we're very, very aware that older people do not receive the quality home support services that they need to maintain their health and well-being and to allow them to continue to live independently within their homes, in their community, and indeed to avoid or even delay hospital and residential care stays. Home supports are critical for older people, and it's clear from our work that families are not getting adequate, quality, affordable home care supports. Indeed, the Citizens' Assembly has dealt with this issue, and the findings were very, very clear. 99% of the members wanted the government to expedite the current commitment to place home care on a statutory footing, and we now have the beginning of that emerging, and we're working very closely with the department to develop that. And a further 87% of people want an increase in public resourcing to ensure that this is delivered appropriately. We all know the demographic challenges. Life expectancy is rising, and people aged over 65 now can expect to live well into their 80s, and 2/3 of these years will be lived disability-free. However, as they age, the risk of disability increases, and 72.3% of the population aged 85 and over will have a disability by the year 2038. Now, I'm not here to labour this. We all know the statistics. They're very, very stark. But the people over 85, this cohort is projected to double in the next 20 years. So by 2030, the over 65 cohort will increase by 59%, and the over 85 by over 95%. This obviously creates capacity challenges, and this has been well signalled. We've had two key reports. The ESRI report on healthcare projections noted that the demand for home care packages is projected to increase by between 44 to 66% by 2030, and for home help hours is also flagged to increase by between 38 and 54%. The Health Service Capacity Review also flags this, and various numbers are there. They're in our presentation. I'll leave it with you. But looking just at home care packages, which you understand is a critical component of wraparound care for people, Currently, this will have to increase by 70% from 15,600 a month to 26,600, and there will be a need for an additional 7.2 million home help hours by 2031. Unmet need, and this is the crux of it. Because of the dramatic democratic challenge, the projections on unmet need in home care supports are a cause of deep concern. And again, various research puts the level of unmet need at varying levels, but at the very, very least between 26 and 50%. And this will cost between 120 million respectively and 205 million respectively over the first 5 years of Sláinte Care. And we will come back to Sláinte Care because it is the blueprint for how we should reform healthcare systems in this country. A report by our colleagues, Care Alliance Ireland, just published a few weeks ago, gives very important information on both the length of waiting times for home care and also the gap between assessed need and the actual service that the person ends up getting. This report is very sobering reading, as despite using a Freedom of Information request to all of the 9 community health organisations, only 3 out of the 9 responded fully to the questions asked. 2 gave partial information and 1 refused outright after an initial acknowledgement. The report found that the average time spent on a waiting list for home care supports for non-priority cases was calculated at least 3.3 months, and the gap between assessed need versus actual service provided was found to be 15%. And more worryingly, the report found an inconsistency of approach to measuring and documenting unmet need. And we all believe in the Home Care Coalition that it is a cause for grave concern when the statutory health provider does not have a uniform approach to measuring, prioritising and allocating need. The actual figures on the unmet need vary from month to month. The various reports give us various stats, but we know that there are at least 6,100 people assessed in need of home care waiting for an initial service. And as I said, these figures vary. We also know Age Action is very aware that the numbers receiving home supports in the community doesn't reflect the accurate reflection of current and future need, because some people, older people, actually opt not to apply as they know that service provision is not sufficient and it will not meet their need. We're also concerned at the actual lack of data on private home care provision in this country. We know that the variety of negative consequences can affect very badly the health and well-being of older people and their families. These range from minor consequences, such as feeling unhappy because housework isn't done, to major consequences, such as being unable to eat when hungry. Older, frail people often sustain an independent lifestyle at home if they can receive the appropriate, timely, quality, physical and psychosocial supports. So indeed, we know the absence of available home supports impacts fundamentally on the range of choices available to old people. Without access to home care supports, some older people are forced to move to residential care setting, which is often not their first choice. And this undermines their human right to live with dignity and independence. Now, very briefly, funding. We, as part of the Home Care Coalition, we know we need a large injection of funding into the home supports to enable the service to at least meet its yearly growth in service users and also to return to the 2008 levels of service provision before the cuts, the austerity cuts. Research, I'm leaving you with a graphic, I won't go into it too much, but you can see that there is a huge disparity between the nursing home support scheme, which is funded to the tune of 962 million in 2018, and that is catering for 23,500 older people in nursing homes, which is 4% of the cohort, while the home supports element of care is at this point now, including the winter initiative, 430 million, and this is a service that goes to approximately 50,000 people or a little bit more, and that encompasses home care, home help hours, home care packages and intensive home care packages. So you can see there is a big disparity there. Now, to conclude, we know, and we know that you know, that there are serious challenges facing the planning and provision of home supports. The deficits have a serious impact on the quality of choices people make, if indeed they're able to make any choice about where they will receive the care they need. So in summary, we know this. The average home care package is now 6 hours a week, not 10 hours as we all thought previously. It's now harder for over 65s to access home support than it was back in 2008. We know the waiting lists still persist. There are now less hours being spread every week, more thinly per client, with an increase in the provision of short 30-minute slots. And when we think about that, there's not an awful lot you can achieve in 30 minutes. There is an absence of legislative entitlement to home supports. There is a postcode lottery, which quite frankly is shocking in service provision, and there is a lack of transparency and accountability. Limited access to packages due to chronic underfunding, and as we said, the eligibility criteria for supports remains unclear. And we know Sláintecare are working very hard on that issue with Laura McGahey. Overall lack of provision of supports is the key issue. And Age Action, we have a helpline and we constantly get calls from people needing to remain in hospital or who need to go to a nursing home because there frankly are not supports at home where they want to return to. This is a serious deficit and we're facing a steep increase in demand due to our population growth. So to conclude, we know that there are two clear messages we need to leave with you today. All of us here are asking for an increase of at least 10% in the home supports budget in each year until the statutory scheme comes on stream. We are working closely with the department, very collaboratively and innovatively, about how we should design and deliver this service, but it isn't here yet. We also know that the Sláintecare implementation strategy has said itself it'll take 3 years to get this scheme in place. So to maintain access and meet the demands of the expanding demographics, funding has to increase by at least 4 to 5% per year just to stand still. Our last, and it's really a critical issue for you to take away as elected members, the new statutory home care scheme must be underpinned with robust eligibility legislation and it must have a quality standards monitoring framework. We all know that eligibility without capacity will not work and needs will not be met. So we know that the development of a robust, equitable funding model will necessitate an honest conversation where collective societal values must be articulated and an agreed approach to the generation of funds to support the scheme must be reached. So we look forward to working with you to make sure that older people's needs for home supports are adequately addressed. Gurv Margaret.
Thank you very much, Ms O'Reilly. So now, can I invite Mr Liam O'Sullivan of the Care Alliance to make your opening statement?
Thank you. I'd like to thank the Joint Committee for the invitation to attend this morning, and I'll share my time with my colleagues from the Alzheimer's Society and the Irish Wheelchair Association. Care Alliance focus is on family carers and supporting our member organisations and others to better support such carers. For many families, state-funded home care provision can be a key support in keeping people well at home. I refer you to a recent report on home care published in October, copies of which I have here. I'm glad to say there is much consensus on home care, the importance of it, the good value it represents, and the likely future demand for it. On the latter point, the 2017 ESRI report speaks of the need for what we would estimate to be a 70% increase in home support by 2030, from a current provision of 17 million to an estimated 30 million hours. And that figure is reinforced by recent correspondence I understand Deputy Donnelly has received from the HSE in their projections on future demand. We welcome the Department of Health review of home care, but are concerned about its slow progress to date. We, alongside a group of over 20 other NGOs, are engaging actively with the relevant department officials in articulating a vision for the future of home care. And we in Care Alliance appreciate that it will take political courage to grapple with the challenging issues of funding. I know the committee last week and discussed the HSE budgetary overruns. To put in context, the likely acute hospital overrun of approximately 225 million represents over 50% of the entire home care budget for 2018. Finally, I'd echo Minister Daly's comments at this very committee last week about the somewhat unhelpful dominant narrative of hospital trolleys, and that the focus needs to be more on how long people are waiting for a service, and specifically a home care service. In that regard, we have specifically asked the HSE to include this as a key metric in their 2019 service plan. Thank you.
Mr McLaughlin, thank you.
Thanks, Chairman. Thanks, members, and in particular members who are part of the all-party committee, all-party group on dementia. I'll focus on two evidence-based projects which we were involved in. One is the de-stress study into spousal carers, 200 plus spousal carers. Overall, you can see that in 2010, family carers and friends provided 81 million hours. That's about 50% of the total amount of investment in dementia. 15% of carers had given up their jobs to care for their spouse. 79% stated that they provided 81 to 100% of the care. On average, they'd cared for their spouse for 5 years at the time of assessment. Only 50% of them had received any home help in the previous 30 days. And of the 50% who had received, they received an average of 34 hours, a little more than an hour a day to look after somebody with dementia. Only one in 4 had received family care training. 71% had 2 or more health conditions at once. These are the carers, including arthritis, hypertension and diabetes. And 1/3 had fairly bad sleep quality, and a further 9% reported very bad sleep quality. About 37% of the carers reported clinically significant depressive symptoms, and 20% of carers themselves possibly had problems with cognitive function. We would argue that if you wrap around services in the community, that there can be tremendous support to carers, and this was mapped by the HSE and ourselves in 2018. But we can see a very different range of services available, from 23 in CHO3 compared to 44 in CHO1. If we look at day centres nationally, only 41% of day centres operated on a 5-day week basis. You might assume that that means that people attend those day centres 5 days. No, they don't. 80% of people attend, from our services, attend 1 or 2 days a week. That's all they receive. 20% of those day centres operated 1 day a week. Wexford, Laois and Leitrim have no day care centre for persons with dementia. That denies nearly 2,000 people access to a service. In fact, if you take 3 counties quite close, Leitrim have 3 services, Longford have 6 and Roscommon have 10. So the point being made about the lottery certainly is true. We estimated, based on evidence, looking at the number of services in an area, looking at the minimum service that should be, and costing that, and those costings were to the satisfaction of the HSE, 12 million would have transformed dementia services in this country. It would triple the services and would provide a basic minimum level of service in each county in the country. The challenge is huge. Estimated that by 2046, the number of persons living with dementia in Ireland will rise basically 3-fold. That needs to be looked at in the context that the number of people over 65 will increase 2-fold in that period of time, but the number of people with dementia will increase 3-fold. Thank you, Chairman and members.
Thank you very much, Mr. McLaughlin. And now can I ask Mr. Joseph Musgrave of Home and Community Care to make your opening statement. Thank you.
Good morning, Chairman and members. Thank you for inviting Home and Community Care Ireland, along with our colleagues from other organisations, to speak with the committee on the issue of how to improve home care in Ireland. I'm joined today by Ed Crotty, who is a Managing Director of Heritage Home Care and a Board Director of HCCI. HCCI represents over 70 member companies, who in turn provide care to 20,000 clients and employ 12,000 carers between them. I was appointed Chief Executive of HCCI on Monday, 17th of September of this year. There are a range of things we can do to improve home care in Ireland. From HCCI's perspective, a non-exhaustive list is that we need to ensure operational changes, we need to increase the supply of carers, to professionalise the caring workforce, to improve trust and dialogue between the key stakeholders, and work together to ensure Sláinte Care success. One of the most pressing issues facing the service is waiting times. Whilst any increased funding to expand capacity would be welcomed, there are crucial operational changes that need to be made. At present, none of the IT systems talk to one another. Those in the acute system do not talk to the public health nurses, and the allocation of home care packages is poorly commissioned. This negatively impacts the ability to foreplan and build capacity. The current allocation of packages, which is done by fastest finger first as per the HSE's 2018 tender, is suboptimal. HCCI would prefer to see a different model that would be uniform across all CHOs, allow providers to participate in holistic care planning, and thus end the widespread practice of inefficient rostering. This would provide more meaningful work for carers. The current home care package is designed to fit all situations, but the type of support needed in rural Ireland differs from that in urban Ireland. Therefore, we need to look at a new funding model for home care. Lessons can be learned from the Fair Deal scheme for nursing home care. As our population ages, and we are all familiar with the statistics, we will need to expand the home care workforce. To do so sustainably and to attract and retain the talent of people that we would all wish to care for our loved ones should the circumstances arise, we need to stop a race to the bottom on pay and increase the pool of available labour. HCCI submitted a case to the Economic Migration Policy Unit to allow non-EEA workers into Ireland to become home carers. We think it is vital that we broaden the base of available workers. In addition, HCCI is currently working on a submission to the Department of Social Protection in the hopes we can end the current system that punishes a worker from providing home care whilst in receipt of state benefits. We need to change the HSE procurement rules so that the tendering process is a tool to improve the conditions of the workforce as well as deliver value for money. The reality is that HSE sets the conditions of the market. That carers do not receive travel allowances except in rare circumstances is a result of the procurement practices of the HSE. Caring needs to become more culturally embedded and turned into a profession with a defined and rewarding career pathway. Innovations are only limited by our imaginations. Why not a mandatory caring module in transition year, for instance? Professionalisation should also spell the end of a singly hourly rate for carers. Specialisms ought to be rewarded as in every other industry. HCCI is pleased the HSE have conducted a review into the career of healthcare assistants, and we eagerly await the results. HCCI welcomes this hearing today, but we are disappointed that the attitude of this committee does not seem to be replicated elsewhere. I wrote to Minister Daly a month after my appointment to request a meeting with him or his officials to talk about the range of issues facing the sector. That letter has not received a response from the Minister. The HSE last held a Home Care Providers Forum in April 2018. This meeting of the HSE, HCCI and the non-profits should be a regular occurrence, and it is deeply regrettable that the meeting scheduled for the 5th of December was postponed without any reason by the HSE. My hope is that in addition to the forum becoming a regular place to discuss operational issues, we form a high-level working group convened by the Department between the principal stakeholders so that we can work together and form long-term policy proposals. We also need more transparency in the operation of the service. Recent work by members of this committee shed light on the current waiting lists, and work by my colleagues at the Care Alliance similarly enlightened us. However, it would be better if the HSE regularly reported a standardised set of figures on the operation of home care across all 9 CHOs. HCCI would welcome the sector's scrutiny and transparency, for only understanding the true picture can we all act on an informed basis. Finally, 2 developments that will shape the future of home care, namely the statutory entitlement to home care and sláinte care, provide a rare opportunity for us to rethink some of our assumptions and design a robust and sustainable home care service. Laura McGahey and her team are, by all accounts, doing great work at this early stage, and I hope for a formal meeting with her soon. HCCI would like to see a framework that draws on the expertise of the relevant stakeholders and meets regularly to ensure that sláinte care is a success. We need to clarify how we will fund the expansion of community services needed to support the reforms, as well as start preparing the entire sector so that it is ready to provide this care. The regulation of home care is vital, and therefore we should be teasing out what model of regulation will deliver the best outcome in the future. Thank you.
Thank you, Mr Musgrave. And now can I ask finally Mr John Dunn of Family Carers Ireland to make your opening statement.
Thank you, Mr Chairman. Family Carers Ireland is a national charity which works to improve support services and recognition for anyone living with the challenges of caring for a family member or friend who is frail, ill, disabled or has mental health difficulties. We use such a mouthful because traditionally there's a sense that family carers look after old people. It's a much bigger agenda than that. We engage with over 20,000 families a year. We also deliver about 1/3 hours of home care a year, and that gives us an interesting insight into the operational aspects of caring. I'd like to formally say we're a member of and support the position of the Home Care Coalition, and in fact we also support many of the points being put forward by HCCI as well. I want to take, our position starts from a slightly different situation though, because there's a good degree of confusion indeed when Joseph was talking about the labour manpower shortages. He talked about carers. Under government policy, actually, carers are unpaid. Care workers or care assistants are people who work in the home. But there is a huge confusion when people talk about caring. I think it's really important for this committee to be clear about that. And our agenda is around the co-production of care, because we would maintain that the state has no remote prospect of being able to afford home care in Ireland without co-production going on with unpaid family carers. Taking the CSO's own estimate and charging it up very conservatively, you're getting €10 billion of unpaid care in the home from families. And the irony is that the way policy is going, it's actually threatening to strangle that and reduce it rather than help it. We're very encouraged, nonetheless, by the emerging themes which the Department of Health has abstracted from the first phase of its consultation. But there are a number of issues that cause us real concern, mainly because they're not being discussed, not because there's a lack of consensus or it's going the wrong direction. The first one has to do with the nature or purpose of home care. This will have to be defined in the legislation, and we believe that the legislation is going to go in the direction of placing primary responsibility on the family, and with the state having a supporting role. We think that's absolutely the right way to go. We think it would command widespread support. Unfortunately, the HSE recently seems to have set its face firmly against this approach, and I don't have time to develop it in my opening statement, but if you want to come back, I would suggest there is a real prospect the state will wind up spending several £100 million extra because of where this is going, with no increase in home care. We come back to that. Funding models. There's a lot of talk about a funding model. In the initial stages with the legislation being proposed, there was almost a rush to the shape or the direction of co-funding. Our position is we recognise co-funding will be required in some shape or form. We are not willing to talk about co-funding the current system, which is completely unacceptable. Therefore, the debate needs to be, what are we trying to fund? We need to define standards for home care. We need to define a model of home care, and then we can discuss how it's to be funded. A lot of discussion centres on wonderful models from overseas, and there's a fair bit of discussion, for example, about the German system. The German system is excellent. It's based on a very sophisticated insurance model. For example, if you don't have children, your insurance premium is higher on the not unreasonable assumption that when you're older, there'll be no one to look after you, whereas if you've got children, they might look after you, or indeed under the German system, you're required to. An insurance-based system was first floated in Ireland decades ago. There's never been any evidence of an appetite politically to address that. Fair enough, we think it's an interesting model to explore, but the reality is you can't deliver nice systems without a proper funding model, and if you're trying to do this based on means testing out of taxation, it's never going to work. Talk about manpower planning. There is a crisis at the minute, as HCCI have said, in the staffing of home care. That crisis is going to get worse, and we, by the way, absolutely do not accept the ESRI and Department of Health or HSE projections. I'll tell you why. For the simple reason they're based on a steady state situation, and over the next 10 years, as part of the demographic shift, unless you can get the ratio of family carers in Ireland up from 1 in 10 to 1 in 5, you will need to be providing massive numbers of extra paid care. That needs to be built into a policy and thought about, and it isn't being mentioned or discussed. The other issue, the other elephant in the room, if you like, is that the HSE itself is massively conflicted in terms of the delivery of home care. And I don't say this as a cheap shot at them. Many of the problems are not of their making. They're to do with failures of policy. But having said that, let's just consider it. The HSE is a major direct provider of home care services throughout the country. Because it delivers services on the basis of historical funding patterns. That means consistent service planning and delivery is problematic. The current system of the CHOs, where each CHO has an independent accounting officer and therefore a degree of operational autonomy, and the new RECOs will have the same, means it's still practically impossible to get a consistent framework across the system as it works at the minute. The HSE definitely emphasises home care, yet I would argue that when it comes to service delivery, this commitment is secondary to the priority it accords to its own internal industrial relations. And that's something that has to be named and acknowledged and discussed, because I'm happy to be proved wrong, but I don't believe I will be. An effective system for dealing with grievances and complaints is essential to ensure quality home care services. That's because you're dealing with individuals who are at the front line with enormous independence and autonomy, usually working unsupervised in somebody's home. HSE systems in this regard are unfit for purpose. That is a direct result of arrangements set by the government, not the HSE. And as I understand it, the HSE wrote to the government 2 years ago asking for those policies to be changed. It doesn't just relate to home care, it relates across the system. There has been no movement on that. There needs to be. In our case, if we have a complaint, it is signed and sealed within 30 days, and that can include either the complaint is rejected or the person's dismissed or anything in between. We've seen cases in the HSE where a similar situation has dragged on for years. There is no reason for that to happen. Furthermore, because of differential arrangements mandated by the HSE in regard to working conditions for its own directly employed staff and for the staff of commissioned services, the hourly cost of direct provision is up to twice the cost of commissioned services at current rates. That is a huge discrepancy, and it's also potentially, if you want to look at it that way, a huge waste of money. That's worth discussing as well, but I don't have time to develop it now. In terms of commissioning, Family Carers Ireland would contend that since commissioning was introduced in 2010, there's been a steady reduction in baseline quality indicators. The shift to a lowest common denominator home support specification, when you put it beside the increasingly complex cases that are now being assigned to the home care system, looks to us like a serious accident waiting to happen. And far from saving money, we believe this year's tender for home support services has resulted in avoidably higher costs of service because of the extent of gaming of the scoring system that was allowed in that tender. And to be clear, I'm not suggesting anything that happened was unlawful, I'm just saying it was very bad policy. Regulation. HICWA was originally scheduled to have assumed responsibility for regulating home care by 2016. There isn't even an alternative date now in place. The implications for failing to adhere to this timetable are not even being discussed or addressed, possibly because a HICWA survey in 2017 showed that 76% of people responding to the survey thought there was independent regulation in place. I'm sure the HSE would rather not be the regulator, but if you're the regulator, the commissioner and a direct provider, you have a massive conflict of interest. This is inevitably a very high-level review of issues, 5 minutes to do it, relating to improving home care. I'm very happy to discuss any of the points later on in the hearing. Thank you.
Thank you very much, Mr. Dunn. So now I'm going to open the meeting to our members, and our first contributor is Deputy Stephen Donnelly.
Thank you, Chair. Thank you all very much for your time this morning and for your statements. It's very useful indeed. Can I ask, really, to whoever would like to respond, in terms of the quality of the service, several of you have suggested that the service is worse than it was, or under pressure that it wasn't under before. Reference has been made to 2008. Reference a minute ago was made to a degrading of the service. So I guess I'd like to start with two questions. One is the service, how is the service doing over time? Is it getting better or is it getting worse? And if it's getting better or worse, in what ways? So there's time per person, there's consistency, for example, having the same carer available to the same person. There's waiting time and access to getting what you need. There's the quality of the care provided. There's equipment that is sometimes needed, and so forth. You'll all know this a lot better than I will. So the first question is, how are we doing, and specifically, where are things getting better, where are things getting worse? And the second opening question I have is, it sounds like several of you have stated that access is getting harder. I presume that means that waiting times are going up, that the amount of care available per person or per home is going down. On the basis that the spending on healthcare per person has gone up every year for the last 6 years and is significantly higher than it was in 2008, what's happening, do you think, if we're spending more and more money per person, if the services are indeed getting worse? Thank you.
Thank you, Deputy Donnelly. Who would like to take those questions? Mr. O'Sullivan?
Sure, I might speak to the issue of access. I mean, it's quite simply demographics. We've 20,000 people entering that 65 and over cohort each year. A proportion of them, particularly those in their 80s, are quite likely to need home care if they want to stay out of hospital, if they want to stay out of nursing homes. So it's a demographics piece. Labour costs, it's a labour-intensive work, and there's no getting away from that. So yes, unit cost hourly rates are going up. So incrementally that will continue. I can't really speak to the issue of maybe quality equipment, but just to reiterate, there was 10% overnight cuts in home care provision in the tough years of 11, 12, 13. They have begun to be restored, but we're still playing catch-up.
Yes, Mr. Crowley.
I run a home care company in Dublin South, in Dunleary and Dundrum area. To answer the TD's questions, I mean, I would say the labour shortage is the biggest problem we have. You know, that we're at full employment. We're paying more per hour than we were, you know, a few years ago. But it's harder and harder to get carers as carers have choice of other employment. The number of hours per client is coming down over time, so where someone might have got 2 or 3 hours a day from the HSE, they might get an hourly visit now and maybe half an hour, as someone said, later in the day, and that's less attractive work for carers, regardless of the hourly rate isn't as important, I think, as the conditions of employment. You know, Joseph spoke to professionalisation of the industry, and that we need to do all those things, and we need to get more carers into the system.
Thank you. Mr McLaughlin and then Mr Dunn.
Chairman, we certainly haven't caused any of the HSE's deficits. 2013 we received 11 million from them. In 2018 we received 11.2 million from them. What has happened is that with 4,000 new people being diagnosed with dementia each year, in effect the services have ended up being rationed. So people who might have been receiving 2 days or 3 days a week in a day centre, that's been rationed. We're paying our staff at 2010 rates of pay, so the differential now between somebody who commenced in the HSE in 2010 versus 2017 is now 5,500 per annum for a care assistant who will be providing direct care. We evaluate satisfaction with our own services. It's consistently high because we have the same staff, they have empathy, they've trained, and they're not into clock watching or not into pressure to go to another client. People with dementia and their carers say to us, even if the state can only give us 7 hours a week, would they give us the flexibility as to how that 7 hours is used, rather than giving it 1 hour a day to look after, to maybe get somebody ready to get up in the morning. By the time the carer comes, they're already up in the morning. They may be living in a rural area, they can't get time to even go into shop. So there's a basic issue about, even if you can only give a certain amount of hours, please give families and carers an opportunity to have some role in relation to determining how that's provided.
Thank you. Mr Dunn.
Thank you. Just some examples of reductions in care. When tendering was introduced in 2010, organisations were allowed 48 hours to match a care worker to a particular case. In some parts of the country, you're now given 4 hours. You're often not given details of the case you're being asked to match to. There's not even a pretence of trying to get suitable matching. Be one example. We've gone from requiring staff to have a full QQI 5 level qualification by 2012 to now a competency assessment approach, which actually costs deliverers, in our case, the guts of 100,000 a year to administer this monster, which is really a way around, or a way for the HSE to say, yes, we've checked thoroughly that these people are competent, or we've made them certify themselves, rather than simply saying, have a qualification. A huge one is 30-minute. I mean, 30-minute calls are poor anyhow, but 30-minute double assists, where you have to do something using a hoist with somebody where 2 staff are working, we actually just refuse to take those cases on the basis that that's a serious risk, and we won't deal with it. But it's normal to be asked to do it, or it's becoming commonplace to be asked to do it. The other one that's kind of it's a bit less tangible, but I would argue that over the last 10 years, there's been a huge stripping out of social care into a pure personal care, verging indeed that the personal care is even starting to get neglected in favour of clinical care. But the social care is very important in all of this. I mean, when you're talking about home care, it's meant to be an integrated wraparound service. It's not just, let's get in there and stop this person from dying today. In terms of where the money's going, I have to say, I agree with Alzheimer's that it ain't going to us. I would point out, because if you cannot get the answers, I'd be really interested. Now, I'm taking a crude figure. There is an office within the HSE, and I'm taking the costs of the leader and the support team and all this, roughly 500,000 a year, which manages home care. There was an office. There's now 2. I don't understand why. You might get to the bottom of that, but there you go. There's $500,000 on the spot. The second question you asked was about access getting harder. Can I just say a word about this, because it has to. We are now. It is becoming routine in the last year for the HSE to arrive into a house and say, oh, you're getting the carer's allowance, then you're not getting a home care package. This is what's going to cost the state money in 2 ways. The first way is the state defended an action from the European Commission in the European courts on the exportability of carer's allowance. It defended that action on the basis that this was an income support payment. It was not a payment for the delivery of home care services. The HSE is now wandering out and saying that's exactly what it is. And the potential implications, the carers allowance income support for carers is $1 billion a year. Exportability will be a significant slice of that. That is reckless lunacy, frankly. I don't believe it's been done intentionally, but it does reflect a style of policy making, and it is what HPCI were saying, a style of policy making which involves this is what we're doing, no consultation, no discussion. Instead of bringing people into a room and saying this is what we intend to do, tell us if there's something wrong with it and we'll see if we can fix it. The HSE seems to like to learn, not just by bumping into things, but by jumping off cliffs and then discovering what's going wrong. The second problem, just as an example, is we've had people who were told that in order to get services and that they actually needed as part of a home care package that they couldn't do themselves, they had to give up their carers allowance. We had a case of somebody who did that and then went back and said, I've given back my carers allowance, and they said, sorry, we've no budget to give you support. We had another case where the family, the able-bodied young adult son was required to move out of the house before they would consider that home care was needed. That's how hard it's getting to get home care now.
Thank you, Mr. Dunn. Ms. Duffy? Yes.
Sorry, can I just add to that? I think it's important to remember, just based on what John has said, that we're actually moving towards penalising rather than recognising family carers. So, if we're going to deny someone home care on the basis that someone's receiving carers allowance, I think it's important that we remember that only a quarter of all carers receive carers allowance in the first instance because it's means tested. And for those that are lucky enough to receive carers allowance, they receive €16 more than the basic social welfare rate. So by rationing or withdrawing or denying home support to that person, we're actually telling them you would be better off on job seekers or just not on the carers allowance. We also, complicating this is also the fact that carers over 70, their carers allowance is assessed in the means test for the medical card. It's not assessed if they're under 60. So it's just, there's a litany of ways that we're penalising and punishing family carers rather than recognising and rewarding them. The pension is another example, but I leave that one.
Thank you very much. Deputy Donnelly, one more question?
Yeah. Thanks. Thank you for all of that. So it sounds like time per person is going down, the level of qualification required is going down, the availability is going down, the waiting time is going up, and the system is being extraordinarily badly administered in a variety of different ways. So the final question I'd like to ask is, well, the first bit is just in response to very clear frustrations, which you're obviously all managing on a daily basis. Is anything working in the system? What's going well in the system? And also, can I ask, in terms of the different types of support available, so one of the presentations listed home care, home help hours, care packages and intensive home care packages, because we know there's been a shifting from sort of discretionary home care or home help hours to these care packages, which in some cases make sense. Certainly in cases I deal with in Wicklow, they don't always make sense. So the first question, I guess, is what is working? What are the successes in the system that we should be building on? And secondly, how is the mix working out between the different types of package available, as in package versus home care versus home help hour and so forth? And is there an opportunity there to adjust the mix, to bring in additional ones, to stop doing particular ones or so forth? Thank you.
Yep, Mr. Musgrave.
I'll take the first question, Deputy. So HCCI welcomed the development of clinical governance in the HSE's 2018 tender, which many of my members is taking to mean, having a qualified nurse or someone similarly, and codifying that is a good thing. It's a baby step towards what regulation might look like, and we think that's important. So that's one tick, if you like. The effort by carers remains, I think, immense. So I was at the HCA Carers Conference a couple of weeks ago speaking to a room of carers who, some were angry, but they got a much needed pat on the back by a lot of people for the work they do. And that sort of goes, I think the work of colleagues here, they would testify to that. We also have a lot of expertise now in the system. I think now that we have been operating for over a decade, that we've built up and we've learned a lot of lessons. I think the frustration, particularly in this room, is that expertise doesn't seem to be capitalised on. So again, whilst I would call that out as a positive development and a good thing, it's a shame that it doesn't seem to be taken much advantage of. And I'll let others speak to perhaps your second question in more detail.
Mr. McLaughlin.
I suppose, Deputy, what's working for us is fundraising. That we've been successful consistently in growing our fundraising to 3.2 million now, which is shoring up the state services. On a positive note, I'd have to say that the National Dementia Office are including persons with dementia and carers on all of their working groups, looking at diagnosis, post-diagnosis support, care pathways, all of that. So that's positive. But when we come to negotiating the SLA's service level agreement with the CHO areas or with the national HSE, that's just set at naught and there's no further funding. We also would be very supportive of the Understand Together campaign, which is raising awareness of dementia services, but it's raising awareness and then those people ring a national helpline provided by our volunteers 6 days a week, and they have to tell them, well, sorry, because even though you've come forward, if you were in a county with no services, sorry, there's nothing for you. So we support government policy in relation to the National Dementia Strategy. It's not mentioned in Sláinte Care. We support all of the initiatives that Government and National Dementia Office are doing. We're part of it, we've been included in it, but we're simply not seeing any dedicated resource for dementia and no realisation of just what it's like to be a family carer or indeed a person with dementia.
Mr. Dunn, and then Steen.
Yeah. Just to say, it's inevitable when you come in, especially if you're asked to boil it down to 5 minutes, that you're going to throw out the negativity. I think it's worth acknowledging that there are millions of hours being delivered. It is a valuable service. It's a lifesaver for people. I think that there are individual care workers, not carers, right, within the system, providing a heroic service. I mean, I know we weren't unique in this, but during the storms last year, I had a difficulty because in weather condition red, the rule is service are cancelled. We had people going out bringing meals, making unscheduled, unpaid calls to see that the people they were looking at. That's the positive energy that's in the system. But it's worth celebrating and it's worth acknowledging. Having said that, the system isn't fostering or feeding that. And I know where you're coming from in terms of let's look at the positives as well. Actually, what I'm looking at is the trajectory, and the trajectory is going the wrong way. Dublin is broken. You mentioned the difficulties in terms of Dublin. We didn't even bid to deliver home care services in Dublin, in the Greater Dublin area this year, because it is a zoo. And that's to do with the policies and systems that are in place. It's certainly not to do with the care workers, and it's certainly not to do with the clients.
Thank you. Ms. Steen.
Just a quick comment, and Senator John Dolan would be very aware of this, that a lot of us were working since 2000 with the Department of Health, urging them to define eligibility and entitlement to service. We still do not have that, and I do not envy Laura McGahey and her small staff at the moment untangling that one, because, Deputy Donnelly, that is the legacy of our extremely bizarre hybrid health system that we have inherited and have managed to just evolve incrementally over the decades. We don't have a strong and robust eligibility and entitlement framework. So therefore, the HSE, quite frankly, has myriad ways, and indeed in the 9 CHO areas has different ways of measuring need, allocating need and prioritising need. That, quite frankly, is shocking. In a small territory of a few million people, not able to know what's happening and projecting adequately, and our colleagues have told you what's coming down the track here, this has got to stop, and it needs to be addressed very quickly.
Thank you very much. Now I'm going to bring in Deputy Louise O'Reilly.
Thanks very much. Sorry I wasn't here from the beginning, but I was watching on the monitor. And thank you for coming in this morning. I have a couple of questions, and I suppose if I just fly through them, they're pretty much questions for all of you, so if you just take a note of them. First, I want to inquire about the rates of pay that are paid. So we know what the rates of pay that are paid to the HSE directly employed home helps. I'm curious about the difference between to know the average rate of pay that would be that would be paid to the home carers, because I think that pay and conditions are actually central to the recruitment issue that I think you've all alluded to. The number of hours that have been allocated appears to be going down, as in the average number of hours per person is going down, but the number of hours being allocated is actually going up. And I think this is where sometimes you'll often see the Minister for Health loudly proclaiming there's a percentage increase in the number of home help hours, but in real life and in my advice clinics and in my office, people are coming in saying they can't get home help hours. So there is something of a disconnect there. So just with regard to the home care packages, and mention was made of the 30-minute call, have you encountered a 15-minute call at all? And perhaps you could comment on that, because I have heard of that myself. It's something that really that shocks me, and I think that collectively those agents that provide home care, I think, should be saying with one voice to the HSE that there is a minimum standard and there is a minimum number of minutes. Me personally, I think that should be a minimum of an hour. I think a half an hour is not right, but I do think 15 minutes is beyond. But I have heard of that, so perhaps you can comment on that. Mr Dunn, you mentioned that the way the tender process is construed, that it is possible to game the numbers in some way, and I would like you to elaborate on that, because I think that is something that we need to get a bit more information on. And I'd like to ask you individually if you would subscribe to a national minimum standard in terms of the terms and conditions. And I'll say, just cards on the table, and some of you may be aware of this anyway, I used to represent home helps, and represented home helps in the HSE in the voluntary sector, regrettably not so much in the private sector, but there may have been some improvements in that since I moved on. But the one issue that was raised with us by our members was around stability. So, you know, and the work is there. This is the thing I could never get my head around, because clearly there was a demand for the service that they provide, and yet the contract could not reflect that. So it is my belief that if there was standardisation in terms of terms and conditions, so if there was a standard minimum rate of pay, a standardised contract, that we wouldn't have the issue with regard to recruitment, because very often when people leave the home care sector, it's not to go to jobs that pay a dissimilar rate of pay. The rates of pay very often are very similar, but what's different is the stability. So you might work on a shift, but you're working 8 hours a day. Your shift pattern may change, and you will know this, but I'll say it anyway. You know, they are some of the most flexible workers in the workforce. I know this myself, but you guys will know that anyway. So what they look for only is stability of income, and, you know, the capacity to plan in a small way. And very often when they leave, they do leave for shift work. So it's not the awkward times. It's more being able to say, well, I definitely know I will have 20 hours work next week. So in the context of rising demand, I could never understand why the HSE wouldn't commit to that contract. But I'd be interested to know your own views on a standardised contract in terms of guaranteed minimum number of hours, given that we know that there's going to be an increase in the demand for home care. Mr McLaughlin, you mentioned that your funding over a long number of years had gone from €11 million to €11.2 million, and perhaps the other organisations might be in a position to comment on their funding. Funding is possibly the wrong word, but their contracts with the HSE and what direction that is going in, because it doesn't seem to be moving very fast for others. I'd be interested to know that. And finally, do you see a role for HICWA or a similar agency in being able to provide the regulation, because it is any lone worker, any person who works on their own, be they in an office or, you know, where you deal with the public and you work on your own, regulation is very tricky. We know that. But would you see a role for HICWA in terms of bringing in that regulation? Would you see a role for another agency? I can see the difficulty with the HSE being the regulator and also the Commissioner of Services and also a provider. I mean, you can see how that, that's going to cause some issues. We have HICWA already in place. Could you see HICWA's remit expanding, or do you see that that there might be a role for another body? Okay, thank you, Chair. That's my question.
Thank you, Deputy O'Reilly.
I don't mind taking some of those, Chair.
Yes, Mr. McLaughlin.
I've outlined already the fact that in our SLA with the HSE, we haven't been able to pay our staff an increment. We took our cuts in 2010. No member of staff has taken an increment since then in ASI. Our allocation of hours is going down because we don't provide generic home care services, so we weren't able to, we didn't get the tender. So our home care footprint is reducing by anywhere between about 8 to 12% each year. I'd support national minimum standards, absolutely. The number of intensive home care packages at the minute for persons with dementia in the community is just 178 and is not allowed to grow, as far as I understand, unless somebody dies or goes into residential care. Totally support the idea of a separate regulator because it really is dreadful what's going on at the minute, that if you have a respite centre which provides 1 week of respite for somebody with dementia, there will have to be a nurse in charge right throughout that evening. Nobody else will be allowed to give a drug to the individual. There will have to be a care pathway for it. So for the 51 other weeks of the year, there is nothing like that. But for the 1 week, there's an app. The state goes very self-defensive in relation to how it provides care, so we absolutely support it. In relation to the movement in our budget in that 5 years, we have moved our fundraising from about 2 million to over 3 million, and that's really what's propping up the system.
Sure.
Mr. Musgrave.
I'll take on some of these questions as well. So I'll start with the point about regulation, Deputy. HCCI does support an independent regulator. The more pertinent question, though, is the model of regulation. Would you have a compliance model where you're sending inspectors into people's homes, which would be quite invasive, or are you having a license to operate model from existing providers? So I think that's probably the more interesting and complicated question is how you would actually regulate the sector rather than who would do it, although I agree that the HSE shouldn't do it because of the conflicts of interest. On the funding point, obviously HCCI doesn't receive any funding other than my members. But my members, similar to what Mr. McLaughlin was saying, most of them are operating on legacy rates. The HSE haven't updated the rates of pay, the hourly rates of pay they give, dating back to 2008. So some carers, for instance, will be going into one home at this rate and another home at that rate, which is unusual. I think the tender ties you in for 2 years, and the HSE refused really to touch it or reopen it. I'm going to return to your point about national minimum standards because I think that's the largest topic. 15-minute call, I haven't heard any member report to me about a 15-minute call. The rate of pay, it averages probably around 14 by the time you include weekend work, which is a higher rate of pay, and also holidays and other entitlements. But I think the biggest point, the national minimum standards point, and I'll tie back to the rate of pay, HCCI has a set of national standards that every member has to subscribe to. And I came to this job in September, so one of the things I want to do is looking at updating those standards to perhaps include some of the points you're talking about, because other than the HSE tender, my standards, my organisation standards, is the only one I know that are national, and the members are independently audited against. But the point, I think, here is that we need to look at professionalising care workers, because at the moment we commission services based on one hourly rate of pay, regardless of whether it's a legacy rate or not. We don't say, are you high, medium, low dependency, and therefore you require a care worker who has a separate set of skills. People in my own family are care workers on the front line, so I know this very well. What is the career pathway for that person to develop and incentivize them to get more skills? This is something we want to look at, but the current commissioning system locks you in to a cycle where you're bidding fastest finger first to provide the care, rather than taking a holistic approach, which I'm hoping this committee is getting to the bottom of, but the department and the HSE don't seem to want to engage me on. So we're sort of locked in a little bit of a stalemate where I think there's some good ideas at the table about national minimum standards, but the pathway to implementation and further development seems to me obscure.
Joan Carty.
I suppose I just want to reiterate the tendering process and the fact that it is very geared around the cost and who can provide it at the cheapest rate, as opposed to the quality of service that people should be provided with. But I suppose also the amount of service providers that there are out there, and sometimes in such a small catchment area, services are spread out between several different service providers, which means we're right back to the very piece of how you get to employ enough staff to be able to take up an hour's work here and an hour's work there, where if we were able to in some way reduce the amount of, not the service providers, but within a catchment area, so that the numbers could be spread over a smaller number of service providers, I think then it might give the opportunity to be able to employ people on fixed contracts of possibly 20 hours. And I think that's where the stability piece would come in and kind of raise the bar a little bit.
Chairman, can I just support that? I mean, on a practical level, for example, if you take a home care package in Arklow, right, and so you have a carer who wants to go to Arklow, then you want to add on 2 or 3 more home care packages, so you have a cluster of home care packages in Arklow. But each home care package is commissioned out independently of all the others. So there's no opportunity to, if you take a home care package in I don't mean to focus on Arklow, but if you take a home care package there, assuming your rates are competitive, you should be able to get the next 3 or 4 that come along. So now you have 4 customers in Arklow. You've got 1 carer who goes there and has a whole morning's work. That's kind of what you're saying, really, isn't it?
Mr. Duff.
I think this comes back to the reference I made earlier to internal industrial relations, because you've got to realise that the bulk of the delivery is done by HSE staff. They have block hour contracts. They operate between, if you like, the prime cut hours.
I'm very, very familiar with the contract I negotiated.
Well, we're nothing against it, but then you see what the HSE is doing is it's using the other providers to fill in the gaps around that. And in different ways. We had a case recently in the context of stability. We had a case where, and we could tell these were HSE packages because clearly, it was a 4-hour block in the middle of the day. This is gold to any commercial provider, putting ourselves in that category for the purpose of the tender. So we recruited 12 staff. There was a block of these came to us very suddenly out of the blue. We recruited, put the whole thing in place. 3 months later, we got a call saying, thanks very much, fire all your staff now. Our people are ready to take back over again. So the stability to the HSE staff is coming at the cost of the rest of the sector. That's and I'm not saying that's necessarily what should happen, but that's the way it's being operated at the minute.
No, that's a very good argument, though, for the HSE to be the sole provider. Equally, because they wouldn't, if the HSE were adequately fulfilling demands, well, then there wouldn't, they would have a sufficient pool.
If they could get their staff to work the hours that are needed in terms of flexibility of hours, if they get the responsiveness in terms of disciplinary process and all the rest, I wouldn't necessarily argue with that. But it's pretty clear to me at the minute that wouldn't work. It's not a matter of ideological, it just wouldn't work because the flexibility isn't there. I was at this committee a couple of years ago talking about a guy who was being put to bed at 3 o'clock in the afternoon for the only reason that his HSE worker didn't want to work any later. And now that particular case, as I was told 3 weeks later, has been sorted, but that's the system. Can I come back to some of your questions? The HICWA one, as Joseph said, yes, HICWA are the people who've been most often cited to do it, and HICWA doing it, it probably would have to stop at the front door. And the problem with that is there's very much a limit then to how much you're actually regulating the quality of care. On the other hand, to get into a different sort of model, you're looking first of all outside the health system. I have this mental image of a reasonably elderly lady carrying her adult son up a very narrow stairs because the only toilet in the house was upstairs and the son was profoundly disabled. That's to do with housing adaptation. That is clearly a major health and safety issue. But are we actually going to mandate an initiative which says, OK, this house is unsuitable, so that person has to go into care? And we're moving somewhat in that direction around children first, because once you start putting all these safeguarding things in place, then you walk in and say, this is unsafe. That's the end of it. No debate. No regard to what the family want. I don't know what the answer is, but HICWA certainly would seem to be a reasonable step along the way. The direction of funding, for us, the direction of funding has to do with consolidation. We used to have 50 separate funding agreements with the HSE. It's now been consolidated down to 10, which is very good. But like the other organisations, last year, the big debate, you were told there could be no increase in costs and no reduction in services. The HSE was doing both itself, but that didn't really matter. No increase in costs, no reduction in services. And that was it. Now we went in and we kicked the stuff in and we got some increases here and we got some reduction in services there. But if that's the mindset, and as somebody said, that goes back to the legacy costs are a contract we were awarded in 2008 or 2010. I actually got a contract modification recently to say we'll continue paying you the same rate as was set then to deliver that care. The rate is €14 an hour. And if you're mapping the €14 an hour onto the pay of a home care worker, you're ignoring the fact that, first of all, there are specifications in the contract around management. I mentioned already the competency assessment costs us about $100,000 a year. That has to be paid for out of that €14 an hour. There are 3 pages of policies, and I don't mean a 3-page policy, I mean a 3-page list of policies that we have to comply with. That all costs. So when people say, where's that money going? It's going in bureaucracy, which isn't all necessarily required. It's required. It isn't all absolutely necessary, but it's there, and we're contracted to deliver it. So that's the direction of funding. The tender process and the gaming, you asked me to comment on that. The way the tender process is constructed, you're asked to quote for different periods, so daytime hours, nighttime hours, weekend daytime, weekend nighttime, bank holidays, and whatever. Actually, asked to tender for the bank holidays is a bit strange because there's a statutory definition of what they cost. It's not. It wouldn't have to vary from the basic, or you could tell how it would vary. And we saw cases where, in providing the scoring for each of the rates, there was let's say a notional number of hours that would be provided. Now, it's one of the frustrations of bidding in this competition. You can be certain that the statistics you're being given are all wrong. In fact, it says it in the tender. You can't rely on any of these figures. So people look at the figures and they look at their own experience. And clearly, some people looked at it and said, oh, nighttime rates, sure, there's no nighttime calls, or very, very, very few. So, the lowest bid on the nighttime rate was lower than the lowest bid on the daytime rate, which you would imagine from your background, you would say, if nothing else, that's suggestive of gaming. But the advantage of that is that you get a very significant score by having that ridiculously low rate. That's the gaming. And because you've got the low score there, you were able to get, because you've got a high score for the low price on nighttime rates, you were able to charge a higher rate for the daytime rates, which is where most of the billing is coming. And you didn't get penalised because you'd offset the penalty with this low score. So that's the gaming. So people got through with the higher hourly rate on the daytime than would have been optimal from the HSE's budget point of view. There's a secondary issue, which is that the low rate, this goes into your question about rates of pay. The low rate, we would argue, is borderline, if not actually below the minimum wage. Now, it's not below the formal minimum wage, but the reality is, and people talk about travel, and they talk about travel and travel expenses. The key cost with travel is time. And it is a requirement under European law to recognise travel time. It's not a requirement under Irish law. So it is one of these interesting ones. But European law obviously takes precedent until when it's triggered in Ireland. Up to now, it would have required a court case to trigger it. But interestingly, there was a development in the European Court of Justice the last fortnight, which has opened another avenue for that. But the travel time is the huge expense. And when the HSE is paying its own staff, it pays them a slightly higher rate, but I wouldn't begrudge that. There's all sorts of flexibilities that organisations like us can give in terms of, let's say, a little Christmas bonus or whatever, that you can even it up in different ways. But the big difference is travel time. And the thing that mystifies me most of all, because I'm a very innocent little guy, if we're contracted to deliver a package from 9 to 10, we deliver a package from 9 to 10, yet if I talk to somebody, particularly in Dublin, who's asked, they say, what does 9 to 10 mean? And I say, what do you mean? It means 9 to 10, but apparently it doesn't. There's people who will take their travel time out of that 9 to 10. And I'm wondering if you're 15-minute, because actually I think at this stage, even if the HSE wanted to give out a 15-minute package, I think they'd have to pay us 30 minutes under the rules of the tender, so I think it's probably gone. But I wonder if, in fact, people are experiencing a 15-minute care package because a chunk of time is being used for travel.
No, specifically I was asked by a home carer who had been approached to work for 15 minutes.
Can I just maybe add to that, that I've just finished up a series of 7 regional forums with carers all around the country, so about 50 to 100 carers coming together. And at every one of those forums, carers have mentioned at least once 15-minute calls, half-an-hour calls. And yesterday in Donegal, I had a girl whose mother with dementia was getting a 20-minute call to get her out of bed and washed. So I just kind of want to reiterate what Pat has said, that, you know, families very often are made, they're so grateful to get anything. It goes back to the quality. You know, quality sometimes doesn't come into it. They're so grateful to get anything that they just take it, and they don't complain. They are terrified to complain when the quality is questionable. And as Pat said earlier, and it's worth saying again, but, you know, we have this expression in Family Carers Ireland that sometimes, you know, home support hours are inflicted on the families. You take whatever hours you get when they're given. It doesn't suit you at all, because actually between 9 and 10 you're there in the morning, but you'll take them because that's all that's going. So I think it's an important point to restate, and also the fact that people won't complain. And even about, you know, the shorter calls, they won't complain because of the fear of the consequences and the repercussions of that.
Thank you very much. Deputy O'Reilly, I'll move on, and we can always come back to you if you have other questions. So, Senator Colin Burke.
Thank you very much for your presentation here this morning, and thank you indeed for all the work that you are doing in this very important area, and it is a growing area. Could I just go back there to the cost issue and the tendering for contracts? I was given figures going back some time ago, for instance, where private home care providers are quoting something like 22 or 24 euros an hour. And they were arguing with me that when you take out what they're paying to the staff, which is obviously the hourly rate, you then add in your cost of administration, your cost of insurance, and all the other costs associated with providing a service. I'm just wondering, has anyone asked the HSE to give a breakdown of what it costs them to provide home care per hour when you take in the cost of their administration service, their whole cost of insurance, all of that? Because the quote being given to me was that it was costing the HSE something in real terms, something around 32 euros per hour to provide home care. And I'm just wondering if anyone can give us any information on that, because you were talking earlier, John, about...
Sorry, Senator, I wonder, is your phone active?
No, it's not. Sorry. My apologies. Should be.
Just for sound quality.
Sorry. I'm just wondering, you know, have we looked for that piece of information? Because I'm a bit concerned about, you know, on the one hand, the people that are being required to provide the service, and they're being asked to tender, and then the tender has to be, you know, meet the requirements of what the HSE want on the one side, but at the same time, the amount that's being paid out is way under what it's costing the HSE to run it. The second thing is that I have, and that's in relation to the HSE over the last 4 years have taken on an additional 13,000 people. And that's across the board in all areas, from nursing to admin staff to carers. I've heard complaints about companies that were providing home care where a lot of their staff now have been recruited by the HSE and are given fixed contracts, are full-time employed by the HSE. I think there's somewhere around over 2,000. And maybe you might give us some clarification on that, because I understand that Nursing Homes Ireland are having a problem now in relation to retaining staff, and also the private care providers who are providing home care. So I'm just looking for some clarification on that. And I suppose the third issue that I just want to raise is that look, we have a growing elderly population, and you've talked about the figures here, and we've talked about them numerous times. And we're now in full employment. How can we now face into getting more people into providing home care if we're facing that kind of competitive feature now from now on? And the issue, for instance, in relation to bringing in people from abroad, I understand that there are difficulties in that, but it is a challenge now. The people who are providing home care privately are having the challenge in recruiting workers. The HSE, in fact, have difficulties in some areas as well in getting people carers, despite the fact that they are, and that they are giving a reasonable rate to people. So we're now facing a major challenge in that whole area. And how do we now deal with that challenge? And the final thing I just want to touch on is where the HSE is providing home care, and I've come across in a number of cases where there's a major difficulty at both weekends and in particular public holidays. And how do we now deal with that issue, where on the one hand HSE are providing a very good service in 9 to 5 or 9 to 6 or 8 to 6 maybe in 5 days a week, but then at weekends and public holidays there's a major problem, and there isn't a private there isn't any company available to provide the care over the weekends. And particularly I'm talking about people who are living on their own, where there is no immediate family around them. And how do we now face that challenge as well?
Thank you, Senator. Mr. O'Sullivan.
Thank you, Senator. Just around the HSE costs and your reference to 32 hours, I know in our research over the years we've made assumptions because, to be frank, the HSE couldn't give us or wouldn't give us that data. We looked originally at 20 euros per hour, more recently at 25 is the assumption we're going on. I'm not convinced. I think it's probably closer to 32. I think there's the pension costs and the travel costs that maybe aren't reflected properly in their costing. So say when the Minister announces an extra 100 home care packages, the cost basis for that, I think, is a little perhaps naive. Perhaps the committee might want to seek that information directly from the HSE. We'd love to hear it. Around the reference to increase in staffing, you're spot on. There has been an increase in staffing. The reality, in spite of the reference to primary care being crucial, hospitals continue to recruit more staff. They continue to overrun their budgets massively, but by a factor of 5 or 10 compared to home care and community care. Just an example, I mean, there's been, and I know the committee discussed this last week, I understand, there's been an extra 47 public health nurses taken on in the last 3 to 4 years, 3% increase. If you contrast that with the 27% increase in grade 8s and above, you do question maybe the priorities. And finally, I think around the foreign care workers, the reality is that will be a future supply of care, and valuing that and giving people the legitimacy to be employed legally here is really important. And I know a number of the not-for-profit organisations have made representations around reviewing the criteria and deeming that care work being in short supply to make it easier for people from abroad to come here and work legitimately. I think that's going to be part of the solution.
Mr. McLaughlin.
We don't have information specifically on the cost of HSE care, but I absolutely take your point in relation to reaching in effect full employment, and where we're noticing difficulties is we get about 2.4 million from the Department of Social Protection for community employment schemes, and they represent about 1 in 5 of our staff in effect at the minute. So we have situations now where we're finding those CE workers difficult to replace. And what happens in that situation is the Department of Social Protection is showing a saving, and the Department of Health then have to fight for the additional resource, maybe 19 hours, which is being used by that CE employee. I've raised it with 2 junior ministers or ministers of state. I've said, look, this doesn't make sense. There's a pot of money there in our situation, about 2.4 million, that if we put that towards a proper training programme and a career structure so that people could work in areas like dementia or with Alzheimer's and then be available into the marketplace. So some private providers have come together, I understand, in relation to that, but it needs to be made attractive. We are losing staff to the HSE. I don't want to over-egg that, but we have noticed a trend which probably will be even more difficult, that staff who are working very much part-time with us have advised us that they're working part-time with a private operator and that they're also doing private hours for individuals. Now, that puts the individual staff member in a very difficult position. They're dealing with 3 different sets of rules, policies, procedures. They're dealing with Garda vetting for providers. They're dealing with safeguarding issues may be dealt with differently in different organisations. So we have a very difficult situation out there, I know, for part-time carers, and it would be much better if there was a proper career structure, proper training path for that, and that money was utilised from social protection and put towards a proper training programme in health. It would be our view in ASI.
Thank you. Mr. Dunn.
Echo the comments of other people in terms of I don't think anybody knows what the cost, including the HSE, what their cost is, and that's not a cheap shot either. My last job when I worked in the public sector was to approve a budget for an organisation like the one I'm now involved with, and I went through it with a fine-tooth comb, lots of red lines, whatever, and ironically 3 months later I found myself running the organisation and trying to deliver the project on the budget, and I just learned how sheltered, if I can put it like that, the public sector is in terms of costing a service. But I think it's something the committee could usefully dig into, and I'd go further. If you did get an answer on it, I'd be very happy, and I'm sure some of the others would as well, to come back and give you the benefit of our insight on the cost structure that's being presented to you, because, as I say, we do it every day. The HSE and fairness managers in it don't see most of the costs associated with the service. They see the direct pay costs, they just don't see the rest. The number of people going into the HSE and losing staff, yes, as Pat says, I wouldn't over-egg it, but it's true, definitely. But I will tell you where it's had a difference, because in 2011, in the good old days, when the QQI training qualification, or FETAC, or HETAC as it was, FETAC as it was then, when that was specified, we actually trained all our staff up to it. It cost us, again, tens of thousands of euros. People were saying, oh, we can't afford to do this. No, we said, if that's the standard, we're going to meet it. We've said we'll meet it. We've lost those staff. We don't spend money now achieving a standard that isn't required, on the basis that if we do achieve it, anyhow, the people will be taken away from us. So there is a dysfunction there, but the shortage of staff are getting cannibalised. We keep an eye in terms of metrics on staff turnover, and we're pretty happy with our staff retention rate. But we definitely do lose people, not just to the HSE, we also lose them to the nursing home sector. And it is when people get to a point where they need a block of work that they can rely on. We cannot give them that, we cannot guarantee it, because if you want a block of solid work, you go to work in the HSE or you go to work in a nursing home. And it's only if casual, flexible hours suit you that you work in our sector. Whether that's good or bad, that's the reality of it. Deputy O'Reilly's argument for a set of national conditions, though, are kind of relevant here. We wouldn't have any difficulty, frankly, with that at all, but they'd have to be the same conditions everywhere. And the one thing I will say is we are demanding of our staff in a way that I'm not convinced procedurally, let's say, the HSE is. And I think that's an issue which just needs to be sorted out. Weekends and public holidays, interestingly, we just got a request from one part of the country where the HSE asked could we help them over Christmas and the New Year, and we said certainly. But we do, our own packages are required to keep working over Christmas. We're now a 365-day organisation. And if we're due to do something on Christmas Day, we do it.
Thank you, Mr. Dunn. And Ms. Dean?
Yes, I'd just like to draw the conversation back to, we're talking about people. We're talking about frail, vulnerable people, their loved ones, their family, their communities. I absolutely respect, and indeed have been welcoming deeply, the degree of technical expertise by all of the stakeholders here, and I'm sure that deputies and senators are welcoming of that too. But I really need to remind us all that apparently the culture and values of the HSE is care, compassion, trust and learning. Now, I happen to be a member of the National Patient Forum, and we have marvellous, creative and very inspiring discussions about co-production and co-design of services. I'm not hearing any of this today, and I just want to bring the person back into the room, that as we speak about the technical back end of all of this, which is quite flawed and obviously failing and unfit for purpose, that every day and every hour there are people in absolutely unacceptable conditions, and their families and their carers, and Age Action is not at the technical end of this conversation, so we are leaving that to our esteemed colleagues. But really, the calls we get in our organisation are quite frankly heartbreaking, and the people out there do not know what their entitlement is, do not care frankly what the back office technical end of it is, because they are suffering. And as Yeats would say, we're in the rag and bone shop of the heart, and you as elected members have a very big responsibility to be part of the discussion, the robust discussion which must happen in our society about how we are going to end up with the statutory home care system which is adequately funded and which meets need.
Thank you very much. Mr. Musgrave?
I agree with Audrey's comments, and particularly because of that. That's why it's incumbent, I think, on us all to try and grapple with the technicalities. On your point, Senator, about the HSE's cost, the point has been made. I would just reiterate that other than FOI requests, I don't see how we get the information. They haven't met with my organisation, the non-profits, since April of 2018. Which I think for an operational form designed to get to the heart of a range of issues is unacceptable. Your next question about HSE recruitment of staff, again, I wouldn't overwreck it, but it does come to the heart of the conflict of interest as Commissioner of Care and hiring staff that the HSE can, and I've heard some of my members tell me this, that packages almost seem to be launched in pilot in some areas, and then once the HSE establishes that the packages and can be run regularly, they then hire staff, and that leaves my members and others, I'm sure, in a difficult situation, perhaps having to let carers go if they can't find other work for them. So whilst the specific issue of recruitment of staff may not be the most burning issue, certainly the conflict of interest is, I think, one that needs to be, we need to come back to. I'm going to come back to your other point in a second, but weekends and bank holidays, you know, as John said, is something that my members are required to do and do provide, you know, 24-hour care. And, you know, I know my own family circumstances of, you know, people who are on call having to leave all hours and all family functions having to go provide care. So I've certainly seen it in action. Getting more people into home care in the workforce, I think this is a combination between capacity building and improving the conditions. So on the capacity building point, you know, HCCI submitted to the Economic Migration Policy Unit a proposal to allow non-EEA workers into the country. I think we could do this and we could be innovative about it. We could perhaps take an approach where we look at where capacity in each CHO is low and try and figure out, first of all, like how many more staff do we need and what's the availability. But the fact is that the mechanism currently doesn't exist, and we don't have the tools to answer it, even if we did have that. So what we're asking for, I think, is more tools to increase the workforce. And again, we need to Pat's point, we need to step change in how we view the workforce, the career path, and professionalisation. I think is key to this. On the capacity point, I'm working on a submission, HCI is working on a submission to the Department for Social Protection, because again, you know, some workers, because it's the system, social protection isn't designed at the moment for care workers, that they have a tapering system where you can work a certain amount of monetary, a certain amount of hours and also keep your entitlement. It's done by day. So if you provide a block of 1 hour of much needed care and you want to do this, you're then penalised by social protection to say you can't have your entitlement for that day. Now, I'm encouraged by the early signs the department's willing to listen, but again, I have to work with others on a submission that puts the case, and then hopefully with the support of members to put that through, because that would then release more capacity and more people who want to provide care who are being penalised. And then we've talked again about the commissioning. The commissioning is so important here because it's hard to provide meaningful work for carers, and part of this is rostering, where, as Ed and others have mentioned, you can provide care in every other instance would be a sensible way. Like, you wouldn't send a delivery man, you know, halfway around, you know, you send him on a route. And I don't want to, I'm not saying we send people on routes, but what I'm saying is that if we had a more holistic system and we actually planned more effectively, I think we could give the carers a bigger quality of life and the quality of their work.
Thank you very much. Ms Duffy.
Can I just add to what Joseph has said there? I think that, in addition to the terms and conditions, so much of this is tied into the Department of Social Protection, whether they realise it or not. We have met them in the last number of years as well. Actually, we met them when unemployment was 10%, because we couldn't encourage people to come off the live register and take up caring roles. So we really wanted to kind of get creative and look at what we could do. And they pointed to 4 pre-existing schemes that they felt should address the issue, which it simply didn't. Things like the part-time jobs incentive scheme, all of those, it didn't work. So what we would say is the Department of Social Protection, which now has the employment portfolio, should be thinking in this space, and they really do need to get much more creative. For example, something that existed probably 7 or 8 years ago now was that any carer in receipt of carers allowance carers in receipt of carers allowance are allowed to work 15 hours a week. Any income that was earned during those 15 hours as a home care worker was exempted from the means test for carers allowance. So that was an incentive that tried to encourage people to work as home care workers. Now, I'm maybe not advocating that specifically, but it was a sign of an eagerness to kind of support. So we have 80,000 carers who receive carers allowance. They're allowed to work 15 hours. Most of them would like to work in a paid capacity in paid care work, and I think we should be looking at how we can incentivise those, and it would address issues like the pension issue. It would address the financial issues that they face as well, and then it would help them to stay engaged with the labour market while they're caring. So just to say, I agree completely. We have to look towards the Department of Social Protection, which now has that employment portfolio as well.
Thank you very much. And before I bring in Senator Dolan, could I just ask and make a comment on, from a practical point of view, what triggers a request for home care? Because it depends upon the ability of families to supply support themselves. And many families make extraordinary efforts in supporting their family members, even their neighbours, in remaining in their homes. And I'm aware of cases where people have been kept out of hospital and out of nursing homes by the extraordinary efforts made by family members who are either living with their carer, the person who needs care, or come home to look after them, take time off work. The intervention of the public health nurse, community intervention teams, eventually palliative care teams who come in to look after patients. So there's an extraordinary amount of care provided in the home by family members, which there's never a request for home care because they want to do it themselves. There are other families who cannot obviously do that, and patients who are living on their own, their families, either they didn't have a family or their families are scattered around the world, so they don't have that capacity. But there is an extraordinary amount of work done by family members in looking after their sick and disabled relatives at home. But eventually there's a trigger that there is a requirement for home help or a home care package. It might come from the patient themselves or from the public health nurse or the doctor, or if they're in a hospital, obviously when they're being discharged, there's a requirement. So there are many triggers for the requests for home help and home care packages. And when that trigger is pulled, there's a request put into the HSE, usually by the public health nurse, but it could be by the hospital, and that is then assessed by the HSE. And there I see the problem, because now it goes out to tender. And how is that? What are the criteria for the tendering process? How do you decide what somebody needs and how it's going to be delivered? Because quite often when home care is delivered, it's delivered in a very fixed and strict manner. It might not fit the working arrangements of the people who live at home with this person who have to go to work. So there can be a lack of flexibility when the home care is actually provided. So it may come, as somebody mentioned here, when there is actually help at home. They actually need the help when they're not at home to look after their relative or their friend. So is there sufficient flexibility in the system to do that? But I'm really interested in the criteria used to decide how much home help you get and who gives it, because I'm aware of housing supported housing for elderly people who might have 4 different organisations coming into the same group of 15 or 16 houses, when one person could deliver the home care for the people in that very concentrated area, but you might have 4 different suppliers coming in to give the care, which doesn't make any sense. So is there a joined up thinking in how the tendering process is used effectively and cost effectively? Also, in relation to carers who are providing care at home, they also require respite care. Is there sufficient support for carers who need a rest themselves from looking after their relative? I think that's a point maybe you'd like to discuss. So I think I'll leave it at that. Mr. Dunn.
Can I just say, I don't think the tender is particularly relevant to the questions you're asking. The tender is a way for the HSE to pull in supplementary flexible support for a service it's mainly delivering itself, is the way I describe it. Now, there's huge variations geographically around the country. In some parts of the country, the HSE employs thousands of home care workers itself and provides most of the service and only fills in the edges. In other parts, their history is of outsourcing, so it does flexible. But in terms of the questions you asked, they've just put in place an application process, and the interesting thing is the application is made by the person needing the home care. Not made by a family member, not made by the public health nurse, not made by the hospital. It has to be made by the... Now, I don't know how that's going to work. It's in very early stages. The assessment, as again, you're probably better equipped to, probe this. But my understanding is that the care needs is carried out, the care needs assessment is carried out in two phases. There is, if you like, a clinical stroke social care assessment. Yeah, well, the CSAR, yeah. No, I don't actually even mean the technical. What I mean is, there's people sit down and say, this is what this person needs. That then gets passed to a budget office, which says, this is what this person's getting. Which is an interesting approach, but my understanding is that's how it works. In terms of the flexibility of hours, there was a pilot programme trialled in Clare last year, client-directed home care. And frankly, client-directed home care is a model that's used internationally. And the one thing I'll tell you is client-directed home care in Ireland is nothing to do with any of the international models. But it does allow one improvement, and that is some flexibility around timing and how you phase your hours. And given the industrial relations element of core hours and not outside certain hours, I was curious as to how client-directed home care was compatible with the current agreements in terms of HSE staff. And so I asked what the limits of this, and the answer is it's given to client-directed home care would be offered to people that the HSE feels it would be suitable for. I don't know what that means, but it covers a multitude, and it doesn't suggest a real openness to flexibility and whatever. But it's moving slowly in that direction. There are huge problems with client-directed home care. I mean, handing somebody, which is the other way it happened in care, handing somebody a list of 20 providers when they're at a peak crisis, they're looking for home help. You hand them a list and say, off you go now, sort it out. One of our worries and suspicions is in areas where the HSE is struggling to deliver, even with the assistance, let us say, of the contracted providers, to deliver home care. By handing that piece of paper over, the responsibility suddenly passes to the family rather than to the HSE as the service provider. So there's a lot of stuff to look at, but if you do hear talk of client-directed home care, which you probably will, it's a highly problematic beast, but it may contain the seeds of something that will lead to flexibility down the road.
Well, is that similar then to somebody going into a nursing home? They're handed a list of nursing homes in their area, and they can choose from whichever can provide a bed.
Yeah, the piece of paper that they were handed in the pilot for consumer-directed home care was actually, I would call it monopoly money. It was €200 worth of home care a week. So they're handed a voucher with a monetary value on it, and then they can choose from a list of providers.
This is the successful contractors in that area. So that's what they get, is a list of contractors. But that list is getting longer.
Monetary value that goes with it.
Yeah.
And they go and seek the care from...
So they know that they've been awarded €200 a week in value of care. So then it's up to them to shop around all of the providers in their area to see which one can provide the care. So it's up to them to spend their €200 how they wish, and very often no one provider can provide the €200 worth of care, so it's a jigsaw of all these providers coming together.
Claire is actually making it sound better than it is, frankly. It's a bit of a joke, because at the end of the day, you may or may not get this, then you have to go out and fix it. But the HSE retains oversight to make sure that your care needs are being met. So you go off and you negotiate with all the providers, then you have to go back and get the HSE to sign off that what you've negotiated is acceptable to them. Now, there's good reason for that. You don't want the 200 to be spent on ice cream, but at the same time, all it's doing is creating a huge amount of extra work and pressure for the family.
The €200 voucher in some cases was left behind the clock on the mantelpiece because the older person just didn't know what to do. They were like, what do I do? This list of people. So, yeah, a lot of people didn't follow up, actually. There was months went past that people didn't know what to do with the voucher.
And is there a freedom with that voucher for you to choose a person in the community?
No, that was the list of providers.
It has to go through a recognised provider.
Yeah.
Sorry, Chairman, could I just maybe clarify? Sorry, I know Lee wanted to get in, but I think when you mentioned tendering, how are the packages tendered? You meant each individual case, how is it allocated, or is that what you meant, awarded to the providers?
Yes.
So obviously, as others were saying, the tendering in our terminology is what happens every couple of years, and it leads to an approved list of providers. But you're probably asking about the day-to-day.
Each individual person.
Yeah. So the way that works, certainly in our area in Dublin South East, you get emails every day, literally, from the local health office offering you a case or cases, and then up to recently, you had the client gets an approved list of providers, and up to recently they could say, I want this company or that company. They could rank them 1, 2, 3, and then the local health office would offer that case out in turn to each. If you wanted my company number 1 or Liam's company number 2, they would offer it to me first. If I said yes, I would be awarded the case. If I said no, they'd offer it to Liam, and on down the list. You understand? Mm-hmm. Okay, but that's been changed in the 2018 tender, and now there's a system of, as some of us have referred to it, fastest finger, where they offer it to all the providers, and whoever comes back first, answers the email quickest, gets awarded the case. Now that's not good, because it doesn't give you any time to think about, do you have an appropriate carer? Can you service the whole week's hours, etc.? And at the moment, in our experience in CH06 and CH07, the time lapse is 1 or 2 minutes. So those cases are being accepted by providers within 1 or 2 minutes of the email going out.
Well, is there then the temptation for providers to cherry pick? Because in relation to rural areas, for instance, the private providers may choose to provide care in a concentrated urban area and leave the rural areas to the non-profit providers who have greater difficulty because there may be greater travel times, whereas the private providers can cherry pick within a concentrated population area.
Yeah, I mean, I would call it trying to achieve this clustering that we were talking about before. So if you have a capacity, we're all trying to provide care, we're all trying to meet the packages, and if you have capacity, you'll accept it, and if you don't, you won't, because it would be wrong to accept a package that you couldn't fill. So I wouldn't call it cherry picking. I would.
Well, should there be an equal distribution of the easy ones and the more difficult cases, rather than having the non-for-profit organisations left to pick up the difficult geographic cases and the private providers taking the easier.
Yeah. Maybe I'll step in on partly. The HSE hires a large amount of staff in rural areas and doesn't provide a lot of care in, say, Dublin. So it's partly it's a structure of the way the services are commissioned. The HSE is sort of incentivizing. I think about 60% of my members provide care in Dublin, and that's a membership of 70. So it's the way that the service is designed to be commissioned as the HSE is not actually taking on a lot of the Dublin work, for instance. But also, there's no time for my members to cherry pick. They're given minutes to respond to a package that comes in that's relatively anonymous. in terms of you're getting a very brief profile. So I would push back on an accusation of cherry-picking just because I don't think they have the time. But to your deeper point, when these interventions happen, when a package is awarded, it's usually as a result of, frankly, a failure of the primary care system.
Just in those 2 minutes that you have to make your decision, what are the criteria you're using to make that decision?
Well, you get the initials of the person, the gender, if they're male or female. It varies from CHO to CHO, with some small amount of information about their needs and the hours, the hours that they've been, the times of day that the home care has been stipulated by the public health nurse. So typically it could be an hour in the morning between 9 and 10 or whatever. It could be half an hour at lunchtime. So you get to see that. So the total number of hours per week, what's the breakout of hours, the gender of the person, where they live, their address.
But if you're not in Dublin, if you're in a rural county,
yes,
is the location of the client a critical factor in deciding whether you take the package or not?
Yes, because you have to have the capacity to fill it. So if you don't have a carer who works in Arklow or Ennis or wherever, Mooncoin, then you can't take that. Yeah.
Mr. O'Sullivan.
Thanks. Just to acknowledge, or thank you for acknowledging the role played by family carers. They will continue to provide that care. We reckon about 360,000 day providing that care. So just thank you, Chair. Your point around case management, the reality, even when there's good home care packages, is there's a family member who steps up to the plate and manages those relationships with the care providers, with the public health nurse. Ideally, if we'd perhaps a more well-developed primary care team, that some of that would fall more to the professionals. Your point around respite care, the evidence is clear, the figures don't lie. There's been in the region of a 40% reduction in overnight respite care provided. I can't fully understand what that's about. Is it about regulation? Is it about the HSE getting out of that work because it's difficult to do well? Finally, just around the single assessment on that, you asked about how do they assess needs. We would like to know that, because from our research, it's done in different ways. When we asked the HSE, can you tell us how long people are waiting? Many regions they couldn't. What's the gap between the assessed clinical need and the provision? Many weren't willing or weren't able to give that information, which is beyond belief. The service plan in the HSE annually from 2010 to 2018 have referenced the idea of developing a single assessment tool. It remains unclear to us why this has not been rolled out to date.
Sorry, Ms.
I want to touch on that you asked the question about respite and what availability is there of respite, or what entitlement is there of respite for carers. There's absolutely none. So if you look at someone who, again, is lucky enough to get carers allowance, there's a requirement there that they provide at least 35 hours of care each week, at least. Many of them are providing 168 hours. They have no entitlement to a single day off. I'm entitled to 25 or 26 days off a year. They have nothing. So one of the things we're saying is that respite, a minimum respite provision of 21 days a year, should be included within the statutory home care scheme where a full-time family carer is present. And this is increasingly important where we see, and it was mentioned before, that the family member is more and more often being included within the home care package of support. So where you get a home care package that requires two people, two people to use a hoist or whatever, it's the family carer that's the second person. So they are being professionalised and subsumed within the system, but for no reward. So not a single day's respite are they entitled to a year.
So in your presentation, you mentioned formalising lead responsibility for home care with the family. Is that what you're speaking about? Negotiating with the family member how best to give a home care support and the flexibility around that?
No, it's in the context of the legislation, there are really three systems in Europe. If you step back, you have the Scandinavian system where the lead responsibility is with the state. So the state takes responsibility, but the problem then is if you rock up to the hospital or care home or the local health agency and say, I'm worried about my mother, they say, go away, we're looking after her, or they have the right to do that. You have a second system, which would be some of the former Eastern European countries, where it's the responsibility of the family, and because of that, the state says, we will do nothing for you because you have family and it's their job to look after you. we're saying both of those clearly wouldn't be acceptable in Ireland. So the third model is, and we cite the Portuguese model, not because it's perfect, but because it's a pretty clear constitutional kind of text. The primary responsibility with the family, but the state recognises a duty to support the family in fulfilling its primary responsibility in regard to care, and we think that strikes the appropriate medium, so that's where we're coming at there. There's just from some work in hospital satisfaction, roughly about 18% of people in hospital don't have a family member coming in to see them or in touch, so we take that as, you know, there's 80% have family carers and 20% don't. I'd echo, Liam, I appreciate your comments about carers. On the subject of respite care, in terms of what's happening, I mean, our sense of what's happening is step-down beds, for one thing. A lot of respite facilities have been taken over to deal with hospital. Good, bad or indifferent, that's a dilemma. But the biggest issue with respite, there's been no serious discussion about it. I mean, the Minister last year announced there was a prime time special about carers of crisis. A week later, the Minister announced 10 new facilities opening up to provide respite. I went, mother of God, that's speed of reaction. Then I scratched a bit later and realised he was actually responding to the previous year's primetime special, which was highlighting buildings around the country which had been bought for respite and weren't being staffed. So fair dues, they came through. He announced with some satisfaction 10 million extra spending, all these new beds, great increase in respite this year, mainly for people with disabilities. The reality is, so far this year, the level of respite available is down, like the level of respite provided is down. I don't know where it's disappearing to either, but I do think step-down beds and hospital discharge is probably absorbing a lot of capacity, or taking over a lot of capacity.
A very quick comment to add to what Liam mentioned there about the single assessment tool. Age Action sits on the multidisciplinary group, which is supposedly developing and rolling that out across all of the CHOs. And he's absolutely right. Liam is right. There are serious delays. There's technical issues. And quite frankly, the HSE is burdened with a lot of competing demands. And this is one particular tool which could make one part of it work a lot easier. And it is not being prioritised. And we are deeply concerned.
They do have a, in fairness to them, they do have a pilot. They've got funding to run a pilot at the moment, so they're beginning to dip their toe in the water with some of it.
Mr. McLaughlin.
Yeah, I think, Chairman, you're raising an interesting issue about what the triggers are, and I think the study we did paints a picture of 3/4 of the carers, family carers, had no training. 48% of them looked after the spouse totally, their total waking time. So that's an indication of it. Most carers were on medication, 57% of them for blood pressure. So oftentimes it's when their own care breaks down. I mean, 1 in 4 were frail or were on the road to frailty after just 1 year of caring. And as regards respite, going back to the point I made to Deputy O'Reilly, because of the difference in regulation in relation to respite in the home or respite in a facility which is registered by HICWA, we weren't able to recruit the staff because of pay rates or have the degree of continuity required by HICWA. So we had to actually exit that service. So we have a respite centre with 11 beds lying idle for 2 years. And we're now hoping to contract with the private provider to provide it. So 1,100 people were denied, in effect, 1 week's respite, which would have been superb for them with dementia and superb for carers. So we have an absolute dichotomy in relation to the registration and regulation of home care versus residential care, and a very elaborate system, and I'm not denying that it needs to be that. But when you hold a mirror to what's available in respite in the community, it shows the lack of provision which is there to support family carers.
Thank you very much. I'm now going to bring in Senator John Dolan and then Deputy Durkan. So, Senator Dolan.
I can't honour or indeed acknowledge fully the value of the contributions that have been made this morning. And I pretty much know nearly everybody that has come in as witnesses over many, many years. We use the term in relation to these organisations, service providers, and that is true, but I think we should underline the service they're providing to us today, which is about their reflection, their intelligence, their insight, their problem solving, and their analysis. And I think as a committee we now have a bit of a conundrum. How are we going to start to pull that into different streams? leaving that aside, I think what I've been listening to today, and my apologies I wasn't here at the very start of the meeting, is a proxy for many of the ills and challenges that our health provision, and deliberately not saying a health system because I'm hearing over and over all the things that clash with each other in that enterprise. So I think it would be useful for us as a committee to see, can we reflect on what we have heard this morning, other than or aside from each of the particular things that witnesses have said to us. Because in one sense, I can list out things: hospitals versus the rest of the health system, statutory underpinning versus schemes that are ad hoc or on an administrative basis, and the rug can be pulled out from under you at a rate of knots, person-centred versus system-centred. The social aspects, getting to look at the social aspects of this. Other departments, there's certainly social protection, and as now has been mentioned, the useful involvement they all also have in employment. The housing side, and I'm thinking about work that this committee was involved in earlier this year when it collaborated with a couple of other committees. I think that there's a piece here that's not, we can talk this over and over and over in health, but the solution of it and some of the solutions are in other departments, and I think that's an important thing for us. The institutional care clashing with community and home care. I've said it before, I'm seeing young people going into nursing homes and institutions, and I can't but think that some or all of that has to do with the rationing of supports on the other side. Respite, all of those things. So they're my sort of opening remarks, and they're as much directed at us as a committee, but I wanted to reflect them here, if you like, publicly. Audrey had talked about eligibility and entitlement going back many, Audrey Dean from Age Action, going back many, many years. And that brings us back to one of the things I mentioned, and I'd be offering people if they have any comments on it, that statutory underpinning versus administrative schemes. And if I'm not mistaken, there is a commitment to bring in legislation that opens up a statutory, a fair pitch to play on, yeah, and that would redress, or would have the objective of redressing the pull away from where we want people to be. It strikes me, and in particular, it was comments that Pat McLaughlin made from Alzheimer's. And let me just test this out. And am I right, Pat, in what I'm saying? And then for other people, is this generally the trend? It strikes me that since the recession ended in the end of 2013, that you were giving a scenario that from 11 to 11.2 million of state funding, sort of over that period, and your voluntary funding going from something around 2 up to 3. That's the opposite to the end of a recession. And what I want to just ask witnesses in general, is that more or less what you're all experiencing? If it is, it doesn't have to be exactly the same, but if it is, we really have something that is mammoth in terms of where our health system's going. And how does Sláinte care? You know, our 10-year plan, we're a year and a half after it being put together, we're still not on the road with it. How are these things? Because I think we have a microcosm here of the large ills in the system. If I'm not quoting John Dunn wrongly, I think, John, you talked about social care vis-a-vis home care. If you just Yeah, if you just come back on that. And I want to also see where does this care thing get people beyond the four walls of their home, or does it? Yeah? So, just to draw to a conclusion at that, yeah, an odd, provocative kind of question maybe. We're all hearing about the hospital crisis and the trolley crisis and the winter on top of another. What's your trolley crisis? What's the thing, or can it be expressed that actually captures your side of trying to provide and support people in the community, in the sense that we all have the vision of the trolleys backed up, because nobody sees what's going on here. It's not, you can't send a camera, it can be around the edges of a hospital, or it can photograph the ambulances backed up, but what's the image here of that captures starkly the essence of the problem for people and families?
Thank you, Senator Dolan. Mr. McLaughlin.
I don't mind taking it specifically as it relates to Alzheimer's. It's scary for us in a way to be providing 68% of all community dementia services. I don't think there's another sector where the government and the state are relying to that extent on one organisation to provide it. And that one organisation is paying its staff at 2010 rates. It has increased its fundraising by $1 million.
I wonder, is your device there making a clicking noise? Something is clicking.
No.
Or your iPad? All right, could be that. We've 10 minibuses in need of replacement. We authorised one last week with 437,000 kilometres on it, 12 years old. So in terms of replacement, to gather people in the community and bring them into centres, as I say, about 80% of those get 1 or 2 days service max. So looking back over the period of time, we've relied on the goodness of fundraising, and particularly corporate fundraisers, companies who are giving us money. We haven't been able to pay our staff what we should be paying, what we're competing with the HSE. Our fleet is in difficulty. That $3 million that we earn, by about 6 months we will have none of that achieved in terms of fundraising, because you can't go out after Christmas and start fundraising again. So all our fundraising is late on, from Tea Day into Memory Ribbon Day. So it means you're spending money without knowing whether it's actually going to come in. Our reserves, we've depleted them to try and keep issues going for the state, and we simply cannot continue to do that anymore. That's not to talk about what it's like for an Alzheimer patient to be in an A&E department in this country at the minute, given what's going on. The degree to which they're in a crowded environment, noisy, poor signposting, etc. People who are with Alzheimer's on a waiting list for hip operations and cataracts, and if they're waiting on that waiting list, well then they cannot access our day services, because there is no point in having somebody with difficulties of that nature trying to attend a day service. But it's become extremely difficult to paint that picture in the public arena, and become extremely difficult to paint it with the system we have of funding. So we are seriously underfunded as a sector. We do not want to provide any more services. We actually at this stage would prefer to say we should de-risk the situation, because we cannot provide it. We would welcome the HSE to come and start providing in the counties that we have no service. We have no wish to be the top provider. We're saying we're advocating on behalf of all people with dementia. Who provides the care is a separate issue.
Advocating on behalf of people with dementia, one of the things you did say, and sorry I didn't underline it, the involvement of people with dementia in structures and fora.
Yeah.
And that just reminds me of the UN Convention the will and preference of people, and that sense of being able to, how do you bring people into? But the other point you made, Pat, was you've increased your fundraising by 1%. Am I correct in saying you increased it by 1 million? You increased it by 50%, 2 to 3 million.
Yeah. And we would also be heavily reliant on volunteers in our service. That's the reality of what we face. And we rely on 19 branches in our 15 counties. So that means our cost of fundraising is much lower than a lot of other organisations. We had 1,000 people collecting for us in Memory Ribbon last week. They're all providing voluntary services for us. Many of those are staff of different companies. There are school kids, etc., who came out on a winter's day and fundraise for us. So we're getting huge support from the public and from corporate Ireland, but there just does not seem to be an appreciation of the seriousness of dementia in the country at the moment, and the fact that carers are under serious pressure. Persons with dementia, 10% of them will be under 65. 11 more people will be diagnosed today. One of those at least will be under 65, for which there's absolutely no service for them. So it's an extremely difficult situation, and indeed ASI would welcome discussions with the committee in specific on dementia and Alzheimer's, and because we're not mentioned in Sláinte Care. Our submissions are mentioned, but there's no mention of dementia in Sláinte Care, and our concern is that if we're not mentioned and that bus is leaving the station, that's 10 years we may have missed in relation to getting it as a priority in relation to the political agenda.
Thank you. Mr. O'Sullivan.
Thank you, Senator Dolan, and for your support of family carers and people with disabilities for decades. I think the reality is home care isn't a sexy business. It's difficult to do well. It's messy. It's provided in private, by and large, by family members and increasingly by paid care workers. I would put it back, I suppose, to the representatives and in the media to maybe reflect on how they do respond to those trolley crisis, that kind of dominant narrative, and maybe consider more nuanced responses that can shift the attention towards home care, primary care, keeping people well at home, out of nursing homes insofar as possible.
Thank you. Ms. Duffy.
Just to respond to John, we don't have a winter crisis. It's all year round. The crisis is just there all year round. And it's not as visible as the trolleys that the hospitals have. Ours is invisible because these people are at home, denied a service. So, I suppose it's very convenient for government in a way that they are so invisible, but not so convenient for us. In terms of visualising that, one of the things for me is when I have to help a family complete an application for Fair Deal for young people. And one of the lows of this year for me was when I had to help a family complete an application for their daughter who has schizophrenia and MS and is the same age as me. And it was seen as a huge success that she got a nursing home place within 20 miles of home. That was seen as a success. So that's the visual for me, is when we walk into a nursing home and we see people my age there because there's no option.
Very quick comment. You asked, when does it become visible? And you're right, Claire, it is totally invisible, and the pain and suffering behind the closed doors. But generally what Age Action finds through people who ring our helpline, and I'm so privileged to work with people who have such empathy and caring in their daily job, and the respect and dignity they give each and every call they take. But it's when the quiet desperation spills over into just sheer overwhelm. And they literally cannot cope anymore. And that's a stark indictment of our health services.
Well, I suppose the issue, as addressed in Sláinte Care, is trying to bring home the message that the invisible becomes visible when there's a lack of home care and a lack of support or lack of community structures. So they become visible very quickly. In our hospital system when there's a lack of home support. I think that's one of the key messages of Sláinte Care.
Chair, we need to remember too that acute care setting is the most expensive place in which to deliver care. So really it makes an awful lot of common sense to start sorting out these problems in the community at practically half the price. But it's going to take a really committed planning and very much a political and societal dialogue.
Thank you. Yes, Mr Musgrave.
So just to respond, I think to your first question about the statutory entitlement and whether that would help with the pull away from where we are, it has the potential to. My concern, which I raised in my opening statement, was the sort of lack of a dialogue and lack of a roadmap. So if we're here at point 1 and the statutory entitlement is going to do sort of X, Y and Z in 3 years when it comes in, how do we get to a point now that we're prepared for it when it lands? Because right now, my members aren't being invited in to think about how the statutory entitlement will work. I have a set of national standards, so how do I use that as a tool to make sure my members are prepared for the statutory entitlement? So I don't have high confidence at the moment in how it's being done, because there seems that it's just completely opaque. And I would echo what everyone else has said about, trying to give a voice or an evocative image to isolation is difficult when you have disenfranchised people with disabilities, or people with all sorts of chronic and acute conditions, who in the modern world we react through sort of Twitter and 140 characters and that sort of thing. It's hard to give, and it'd also be a disservice, I think, to give a sort of a flippant response about this is what it actually is, because we have to take to grips with the real world is complicated, and we can't give a simple snapshot, because it's such a wide range of people that we're providing home care to, whether it's families or care workers. It's the reality.
Thank you. Now I'm going to bring in Deputy Durkan.
Thank you, Mr. Chairman. Like others, I thank our witnesses for coming before us this morning and giving us the benefit of their insight into the care system. And just a number of things that come to my mind. Over the years, I've made numerous references to the way the care has to be distributed, and the competition between community-based care and institutional care, and private hospital nursing home care and public hospital nursing home. And the way I see it, Mr. Chairman, I think there's a great deal of competition coming between all those sources now. And I think the demand is getting bigger. The population, the demographics demand that more caring is required. There are competing demands. For example, a house 20 years ago was probably 60,000, 70,000 pounds or euro, whatever the case may be, which was a relatively small mortgage, which family members were able to meet that mortgage repayment and provide care at the same time, very often with a carer's allowance or a supplement or part carer's allowance, whatever. That day is gone now. The demand from the mortgage is much, much bigger, and requires the equivalent of almost a wage earner to meet that payment alone. So now we've divided demands. If you add on to that the family circumstances, what I find in my area is that with older people, if a person is returned from hospital to be cared for at home, whatever the case, very often the family will opt for a local nursing home if it's nearby. The critical question being nearby, both for respite and for support. The other question has been raised. First of all, carer's allowance. The idea in the assessment of carer's allowance is to refuse everyone for a start, or at least almost everyone. And the interesting factor in respect of young people, teenagers and the 20s and so on, would be that it takes no more care than it would a normal teenager or child to look after that one. All rubbish. That's all crazy stuff. It meets the financial requirements, but it doesn't deal with the actual requirements of the child or the family concerned. Because I've seen instances of where it was outrageous to suggest that the child required no more attention than a normal child of the same age, and that in actual fact it created a serious issue for the family if that were to be relied upon. So I think what's happening now, and incidentally as well, there are people in this country now, maybe illegally in this country, from other countries outside the European Union, who are willing to work as carers and constantly work as carers. And I think we need to talk to the department responsible for dealing with them in order to enable them to remain in the country and provide a service, because there's a demand for it. There's not much sense saying to them, you don't comply with the regulations, so you must leave. That's fine from immigration point of view, but it doesn't solve the other issue that we have, and I certainly think there's a necessity to do that and to inveigle them, and incidentally, very good caring people as well from a number of countries. We need also, I believe, to recognise that caring in the community requires a huge input. It's not simple. That was always portrayed in the years gone by as being simple and inexpensive and readily available. It's not so. It requires a huge input. And I hear what the various speakers have said in relation to the costs, and there's a requirement for greater budgetary investment in that area. That has to be balanced. There's no good. I'm saying to you from the point of view of being a member of the government party, and saying, we're going to do that straight away. It's not possible. And if we compare that with 2007 or 2008 or whatever the case may be, the experience from then on wasn't great. And that's why somebody mentioned austerity. The real reason that there were cuts was because there wasn't sufficient resources there to meet the demand, the payment. Government couldn't pay. Nothing there. And I think there's a danger that we might separate that in our minds and say, well, it was austerity that caused it. It wasn't. Austerity was as a result of circumstances that arose, where it wasn't possible to pay the public sector and the private sector, or either or both, depending on the extent to which they were affected. So I think that we need to also look at the extent to which we have competing groups now in the same business. I think you made a reference to that yourself, Mr. Chairman. I would see it much better to have a single authority, a single seamless body delivering the service with responsibility, rather than a multiplicity of people trying to provide the same service, competing with each other for resources, competing with each other for staff, and as a result providing the best they can in difficult circumstances. So what I think at this stage is that we need to look at the entire area once again in a different light, taking into account the increasing demands, the demographics, the costs involved, and trying to find out how best we can provide a good quality service without putting patients at risk, without creating an impossible situation for family carers, and at the same time making it possible to bring people into the service. Well, I'll finish with this. What I've also noticed is that when a family applies for care support in the home, they usually get a package or part of a package, and they might have to wait some time for it. There isn't time to wait. Time may be a very serious issue at that stage, and a week may be a very long time, and sometimes takes 2 or 3 weeks to put it into place. The next part is this, that some of the carers are not as experienced as others. That's putting pressure on their colleagues. And, for instance, there's equipment, lifting equipment, etc., in some cases not being used, not being operated, because there aren't the people there with the expertise to use it. The experience we've had in the past is if an older person, like for instance, an older person caring for an older person, creates huge problems for both. First of all, the quality of the older person who's caring, if there's any lifting involved or something like that, they're not going to last too long at that. It can't work, it can't happen. And I think in those circumstances there's a need for a more systemic intervention with respite in terms of care for a week or 2 weeks, in order to give a breather to the carer in the event of a big family, and indeed to the caring system in general, in order to give it a bit of space to allow it to do the work. What I've said, Chairman, is my own experience in dealing with cases which I'm dealing with at this moment as well, and they all are reflected in the issues that have been raised. They're all reflective of the increasing demand and how to meet it, and at the same time provide them with a good quality care and service which they're entitled to, at least. And they'll all, remember this, they will all tell you, I never looked for anything before in my life. That's the opening statement. Person 80 years of age, I never looked for anything previously in my life. And they feel, and rightly so, that, here's an opportunity now for the system to which they contributed, they work for all their lives, to be able to come to their rescue and do something for them. And I think they deserve that.
Thank you, Deputy Durkan. Sorry, Mr. Dunn, I had overlooked you before Deputy Durkan spoke.
Well, I just felt I owed John an answer to his question about social care and personal care. I mean, there's technical answers. You've got activities of daily living and instrumental activities of daily. Like, there are lists of the kind of things that you'll be doing. And I'm saying the pattern's drifting. In general, there is less of a focus on well-being, mental health, social needs. It's all about get that person up, dressed, washed, possibly fed, and then get out again. There's complications around medication. One of the real shocks to me, because we had been providing in-home care and respite where there was a family carer present, and then we started going into homes where there wasn't. Now, if there's a family carer passing the care worker, as the one is coming in and one is going out, they can say, he, she didn't take their tablets or wouldn't do whatever, and it passes seamlessly back into the house is managing that, or the family is managing it. Where there's nobody else there, the care worker can't administer the medication. So, like, there is a struggle. You're left with, it's recorded, they didn't take their medication. That's not a very effective form of care. So that's what I mean, the experience is... Now, again, let's be fair to the HSE. They're operating on a shoestring budget in this area. They're trying to make, 10 million euros go 100 million euros. They're distilling it back to the bare minimum. So I'm not particularly saying there's an easy answer to this, other than resources is one help. But it's not about people willfully setting out to do this. This is a function of the way the system is going. And then moving on to Deputy Durkan's points, and I'll start with the resources one, because I do take the point it's not austerity, but I am getting a bit resistant to the resources line, because frankly my experience and observation is that when the system wants it, resources are available. And I'll give you two examples. There was the situation of the Waterford Crystal pension scheme, where you had the state coming out very strongly and saying, well, they didn't actually say this, but okay, we messed up, we didn't translate this into law, and that's why that scheme crashed, but we really can't afford to bail that out to the tune of 30 or 40 million. Within 3 months, the state had bailed out a series of Quangos pensions to the tune of 1 billion. Didn't get any headlines. But there's the contrast. We couldn't afford 40 million to do it for one group, but we could do it for this other group, and it doesn't matter what it costs. And what I would say, my real challenge around resources in this, 2 billion to the health system this year in terms of an increase. More or less half of that on pay. Large chunk of that on pay restoration. We're not ready for pay restoration. The resources aren't there. Our sector isn't doing pay restoration, and we're not being funded to do it either, and the state is getting very pious about that. Oh, we can't afford it. But that's where a lot of the money is going.
I hate to interrupt, but we also have before us a group of people almost on a weekly basis who are into pay restoration and who are very aggrieved that it hasn't come, and are central providers to the system. So there are competing demands, and I mentioned that earlier on. And I think we need everybody to be cognizant of the fact that there are competing demands, and it's not an easy place to be. But we also need to be alert to the fact that we can tip over the edge again very, very quickly. We saw it once, and I have this feeling, Chairman, that the boom was one of the worst things that ever happened to us in this country. I think it made us more avaricious in terms of what we deserve, as opposed to what we can afford. And I think that's occasionally it comes to our attention that there are people in the system that get squeezed, who are at the bottom of the system, and don't have the clout or the lobbying power to change anything. And the people that you're talking about, we're talking about here now, are the people, the vulnerable, the ill, the people with disabilities, and the elderly. And they're not in such a great place, and they say it on a regular basis, and the reason is because they feel it. So, and the last point on that one is this, is that we also are told on a regular basis that our spending on health in this country is on par with the higher spenders throughout the OECD countries. which leaves us in an awkward position as well. So what do you do? What do we do?
Deputy Durkan, is it Deputy O'Reilly, you wanted to make a comment?
Just very briefly, yeah. I think it's very hard for the people who are working in home care very often on very low rates of pay to be told, on the one hand, they've never had it so good, the economy is booming, etc., and then on the other hand that there just isn't the shillings there. And I want to make just the point, it's about priorities. So it is very hard for someone on a very low income to hear a proposal in relation to tax cuts when the proposal in relation to a modest increase for them is not being entertained. And it comes down to priorities. And what we hear at this committee time and time and time again are people not with extravagant pay demands, and certainly never people looking for tax cuts, but they're people who come to talk about a crisis in recruitment, exactly as has been outlined for us here today. But the issue is one of priorities. It's not a case of, and we know how high the health spend is, but it is one of priorities. And very often those who are on the lowest pay, particularly home care workers, because they are very much isolated, although they are a big part of the health service, it is very tough for them to advocate. And those home care providers who work for private agencies are also competing with the need for the private agency to make a profit, and that is a fact too. But I don't think it's fair to say that we've people coming in endlessly looking for money. They're not looking for massive money. I think there is an element of having to prioritise, and I would like to see the case for increased home care prioritised, because I think it is a really good value for money service.
Thank you. Yes, Mr. Dunn.
I accept the question of priorities, I suppose, but maybe that's my point. I'm pointing to a differential standard that the public sector provides for itself. It doesn't provide for the rest. I did an exercise in the context of pay restoration, and Pat probably sounds like he's in the same position with Alzheimer's. Somebody on our staff who, in 2011, after the cuts, was on a salary of 25,000. We abolished incremental scales. Somebody in the HSE who was on the same salary, 25,000 in 2011, if neither of them got promoted, the person working for us is still getting 25,000. Now, we're changing that next year for the first time, but they're getting 25,000. The person in the HSE, just through normal incremental and pay grants, is on 31,000 now. I'm not saying that's right or wrong. I'm talking about it as that's the fact.
That's my point.
Yeah. Well, so people coming in and saying they want, I'm not looking for pay restoration. Actually, I'm looking for the opposite. I'm saying I don't know why in God's name we're knee deep in pay. Well, I do, blue flu, but we're knee deep in pay restoration before we were ready for it, because we haven't funded the restoration of services. That's my point.
Sure.
Deputy Burke.
Yeah, sorry, just very briefly. I mean, I referred to 13,000 additional people employed in the HSE in 4 years. That's equivalent, in my view, and I've done a very quick calculation, of 600 million additional pay per annum. And that's 13,000 whole-time equivalents now. There's 135,000 people working in the HSE, including part-time and everything else, but when you boil it down, it's 116,000 whole-time equivalents. In December 2014, it was 103,000. So if you multiply 13,000, the cost of that is roughly around 600 million.
Thank you.
That's where your money is going.
Thank you, Senator. Mr. Musgrave.
Thank you, Chairman. I wanted to respond just to Deputy Durkan's a couple of your points. I think HCCI came in with a submission today that was not all about funding. Whilst we said we would welcome funding, even if funding increased dramatically, what we're saying is that the system isn't designed to cope with increased capacity, and that there are changes that can and should be made right now around how we commission, about the supply of carers, about professionalising the workforce, that can all be done now, and I hope the committee can influence. So I wanted to make that point. Yes, we would welcome more funding, but I accept it's not all about more funding. In fact, my submission is largely not about funding. I I would hesitate to support a single provider of care. Obviously, you can take my view with a pinch of salt, given who I represent. But at the same time, I think a monopoly provider of care would not take advantage of the expertise in the system, would probably not deliver value for money, and would put the committee in a position where you're overseeing, a mammoth body with very little accountability, even less than now, I would suggest. So I don't see how that would provide.
Sorry, I'm not to interrupt, but that's true up to a point. But what do we face with, again, in this committee on a regular basis? We have the private sector and the public sector very often competing with each other, sometimes overlapping, sometimes not overlapping, and leaving gaps in the system. So I come from an earlier generation, as you can see by looking at the colour of my head at this stage, and that means that I remember when there was only one provider, and everything went through that system. And it may have had its restrictions, and it may have its disadvantages, and so on and so forth. But there are multiples of providers for almost everything in the health services nowadays that seem to very often all have good intentions, all well structured, all competing in the marketplace, and very often almost bumping into each other in the provision of service. So that's just as my observation from my vantage point and my dealing with constituents on a daily basis.
Deputy, or Senator Dolan, you'd like
never
to
learn, Cathaoirleach. Anyway, look, I was delighted to hear John Dunn clarify what he had said about the differential standard, because that chimes with what I actually heard him say. And I think there is a point here which goes beyond this discussion. When we hear that the HSE is making more money available, very often an amount of that money doesn't add an extra iota of service, and I think it would serve every interest to actually say, if there's 2 billion extra gone in, half of that or X amount of that increases the cost of delivering a service, so people know what's actually going to enhance a service. And the point that Deputy Bernard Durkan made, we could tip over the edge. All I'm hearing this morning is about people with disabilities, elderly people in need of care, and organisations gone over the edge. So that's the tricky situation, and I think we need to be very clear and forensic about our language when we're talking about these things. Of course, staff have legitimate and valid expectations that things would start to improve, but not just some staff. The person, as was said by Audrey Dean, I think the person getting this, they don't care nor even know who's providing it. It's simply that it's there for them. Yeah? Margaret, thanks.
Thank you, Senator Dolan. Now, Deputy O'Connell, thank you.
Yeah, thank you. I'm sorry for missing some of the meeting. Did I write that down? Anyway, my concern here is, I think this gentleman here has explained this differential in the wages. So am I right in saying that the pay restoration is about 5,000 to 6,000 difference in a carer working in a HSE hospital caring than somebody? No, sorry.
It has to do with, it just has to do with salary progression. So someone who was...
Sorry, just because the same person in 2010 or... Sorry. The same person in 2010 or 11 who started off in the HSE at a 25,000 salary rate, and the other person was in your sector, there's a differential now of 5,500 to 6,000. Is that correct? Yes. Okay. So I assume then that people are leaving your sector and going into the HSE, or is there a drag between both sectors at the minute? I know you spoke about labour shortages. When it comes to this competency versus the NVQ level 5 that you mentioned, in other countries, what do carers have? Are they doing this HSE style form of competency, or is it an NVQ level 5? And there's another issue, under 65s, I've heard that there's an issue that under 65s, there's a huge issue with getting home care in a case of a degenerative neurological disorder or that sort of thing for people. If you could maybe elaborate on your experiences. And what I'm being told in the community is in often rapidly progressing conditions that are a surprise to many families who have never had to engage with your services or the HSE service before, that it can often be 6 to 8 weeks of a family dealing with a devastating diagnosis combined with the patient having to deal with the diagnosis, having no experience in the provision of any sort of care because they've had no hassle up to this point, and that 8 weeks it could take for approval of a home care package, when really, if someone has one of the really progressive neurological disorders, there's no coming out of it. I mean, the end, it's either, you know, the end is nigh, or it's very complex. It's definitely terminal. So what I'm hearing from people is that this is causing undue annoyance and stress in their families, and they have to, at a very difficult time, and often by the time the package is approved, the person could be like, you know, 70% through their condition, and it leaves for a very, very difficult experience. So maybe if you could tell me if that's common, and what sort of impacts you think this has on families in these cases. Thank you.
Thank you, Deputy O'Connell. Mr. Dunn.
Just 3 quick questions. The pay differential, it is leading to a bit of a drag, not a very significant one. The HSE, I suppose, isn't an attractive place to work at the minute, has to be said, so there's that maybe. But when people do leave us, they leave us for massive pay rises. I would say that.
Is that they're going to the HSE, or someone spots them and goes, I'll recruit you, they're headhunted?
Well, they're not just going to the HSE, they're going into the public sector, I would say, at large. Secondly, the qualification for care workers, yeah, it would be the norm around Europe that there is some sort of minimum qualification for care workers.
Have you got that? Have you got evidence of that?
Well, I mean, we'd have to dig it out, but I'm certainly
I'm not being
aware
smart.
of cases.
If you come, and I'm not being smart. If you come in here and you tell us, and I'm on your side on this, you tell us that there's an NVQ level 5, and now there's a competency thing. I think it's a reasonable question for me that you could anticipate that I would ask, what do other countries do? I think it's a reasonable enough.
And I'm saying, I mean, I can't give you chapter and verse. I'm happy to send it to you afterwards.
Please do, yes.
But the reality is, yes, there are qualifications for care workers, recognised qualifications for care workers around Europe. And by the way, it's still within the framework here that people are required to be working towards this qualification, and they are required to have 2 modules of it. But that's after 10 years of initially saying we're all going to have this by 2012. So we have been rowing back on the requirement. Home care packages for under 65s, the reason for the problem is that home care packages are effectively part of the older person's part of the HSE. Now, they can be awarded outside that, but it is an awkward case. When you said 6 to 8 weeks, I was thinking, oh my God, that's fast, not slow. But to be honest, you then made the magic word approval. It's not at all unusual for someone to get a letter saying you've been approved for a home care package, but we'll be in touch when we can give you one.
Okay, so you're a 6 to 8 week approval, and then it could be another chunk of time.
Absolutely, yeah.
And have you often, just in your experience, have you ever seen a case where the person actually had died by the time the package came?
Absolutely, yeah, of course. Problem solved.
All the time.
Not being smart, yeah.
Well, just what can I say to that?
Could I just go back to, I think it's a point that you made, Mr. Dunn, in relation to the lack of consistency of services across CHO groups, that it can vary substantially from one CHO group to another. And if and when we introduce a statutory system, do you think that that will bring consistency to the provision of home care?
Well, not automatically. Let me put it like that. I mean, the statutory framework will presumably define a set of entitlements. In fact, there is no statutory basis for any sort of carer support or home care at the minute. Like, you're really going out on a limb in terms of bits of the Health Act 2004 to come up with a statutory basis. the new legislation will be clear on that. But then you will have a situation where it's all going to be subject to resources, obviously. So you'll have this consistent legal framework, and it will then feed out into, I mean, by the time the legislation happens, presumably we'll be RICOs, we'll have forgotten about CHOs and hospital groups, and there'll be 6 of them around the country maybe, and each of those 6 will have a chief officer who, in fairness, their job is to balance their budget against the demands and the resources. And all that will have changed is there'll be a more standardised set of requirements, but the decision will still have to be made. And the legacy issue, if you have 1,000 home care workers on your staff, well, by definition, you're probably going to be doing more home care work than someone who hasn't, but has, for the sake of argument, 1,000 physiotherapists. I'd love to see an parts of the country like that, because they'd be doing it from that. So the legacy investment spending patterns will also help shape this. This is all about system and policy. It's not about picking out an individual and saying that person's trying to cause trouble there. It's about understanding how the system doesn't work and then how it might be changed. But there'll be a limit to how consistent it will be, as long as you have regional bodies, in fairness.
Yeah. Just before we finish that point, in relation to Sláintecare, there's a proposal that the hospital groups and the CHOs would become an entity.
Yeah, the RICOs, yeah.
Okay. So now, within that entity, they would have a budget.
Yeah.
Well, that's what's proposed.
Yeah.
Right. So now, somebody in one section says, "Well, I'm going to cut home care hours because our budget is at an end." The hospital consultant will say, well, you can't do that, because if you do that, the trolley count in my hospital is going to go up because people are not going to be supported at home. So there will be a conversation within that organisation which hopefully will limit the extremes of budgetary cutting.
No, that's true.
Because one person will say, you can't do that, it's going to affect me.
It won't be the conversations. What will happen is that at the top of there won't be 2 budget silos with 2 different gatekeepers. There'll be a single budget silo with a single decision maker. And that's going back to the system we had before the CHOs, where you had integrated care systems. And we do think that's a progressive move. But I'm just saying, even that by itself, there's all sorts of other issues, and the huge one is the legacy of staffing structures, which determine how the vast majority of the money is spent. When you look at these numbers, they're telephone numbers, but you're really only tinkering at the margins, because most of it is fixed in pay and buildings and all these kind of things. I mean, that's just a truism, you know.
Sorry, Mr. Musgrave and then Mr. McLaughlin.
Just to build on the point from Deputy O'Connell, the question from Deputy O'Connell, what John was saying about time lag and home care packages. So, I mean, of course, Sláintecare, we hope, brings a step change in how we manage chronic conditions and intervention, so that it's not essentially a crisis point that home care package is awarded, as is so commonly the case now. I think Liam's organisation did some work on this, but certainly the priority that different CHOs give per condition varies widely. So you will have wide anecdotal evidence that somebody who has is entering almost palliative care. In some CHOs they'll be prioritised, in others they won't be. And so if you're a family member living in Dublin, but your family member's in Cork, you're trying to make sense and rationalise a system that doesn't make sense. And so it's very hard, I think. I get a lot of calls, and my organisation gets a lot of calls about, how do I understand this system? And I thought that this meant this and it didn't mean that. And so the impact is huge on families. They call organisations like all of ours, and mine is a representative organisation for providers, but I still get calls from people from abroad saying, how on earth do I understand this system? Can you help me?
What I hear is that if the palliative people are involved, things move faster, because that word seems to strike a chord in the HSE. But even if you are terminally ill and you probably have a 12-week window, you don't necessarily tick the palliative box, and you can be made jump through a lot, or your family generally made jump through a lot of hoops. And then, as this man said, sometimes, you've done all this and the patient has died. And you've essentially, to my mind, really affected people's experience of that illness, and the whole family and the carers, but also the doctors and stuff involved. It's very frustrating for GPs and community pharmacists seeing people kind of without anything as such.
Yeah, no, absolutely. And what I was saying is that that what you're describing also varies across CHOs. So in some cases, yes, in many cases that does speed it up, but in other cases it doesn't. That's quite frustrating to deal with. And that goes to the heart of what you, Chair, was saying about will Sláinte Care bring uniformity? Because right now you have a system where some CHOs are on a paper-based reporting system for home care, others accept an electronic system for home care. CHO1 has a new finance system and CHO7 has an entirely different finance system. So we hope it brings some cohesion, but we're trying to deal with the system as it is now. And it's quite difficult to get any consistency. And therefore, you know, when you're designing sort of national guidelines and etc., trying to spread information, you have to constantly caveat it at the moment with, but it's actually very different in your in your local area.
Thank you very much, Mr. Musgrave. Mr. McLaughlin and then Mr. Dunn.
Yeah, I suppose, Deputy, I just wanted to clarify some issues. The fact that somebody under 65 could get a diagnosis today in relation to dementia might mean that they need any support for a period of time, and we would encourage them.
No, I'm specifically talking about degenerative neurological disorders that are rapid.
Okay,
it's rapid,
yeah.
I'm talking about.
No, I suppose anybody with a cognitive disorder, we would encourage them to stay doing what they're doing, stay involved in their
I'm not
employment
talking about
if possible. Where we have difficulty is that where their needs are more complex and their needs deteriorate, that then there's a real difficulty for them and for their carers. That's where the major problem is caused for us. We would encourage, and the HSE would encourage people, continue doing what you're doing, and try and develop coping skills, get cognitive training, peer support, social clubs. There's a whole range of things that people can do to live well with dementia, but it does get to a point where needs are more complex, and then we do need services to kick in very quickly for them and for carers.
Thank you, Mr. McLaughlin. And Mr. Dunn, and then we're going to bring in Senator Burke again.
Just to make the point that it's in Sláinte Care that these new RECOs, the integrated structures, are required or specified that they will use evidence to inform their investment. So they'll do an assessment of needs in their area and respond to it. I say that not convinced it'll work, but in principle. On the subject of palliative, can I just give you an example of a case that came into my head when you were talking about it? A woman, elderly woman, discharged from hospital on a very clear death trajectory, if I can put it like that. The hospital said they can do nothing more for you. You're going to die. Go home. Family said to the family, take you home. The family said we can't cope. Well, then find a nursing home. They found a nursing home. The hospital actually rang the nursing home and said, don't give that woman that bed because we need it. So the woman went home and died. And a classic, because as Claire said, people are frightened to complain no matter what happens to them for fear they lose whatever they're getting. But after they die, of course, after someone dies, you can make a complaint. We had a complaint. We facilitated the family to make a complaint. In fairness, the director of nursing and the consultant in the hospital were quite distressed and apologised profusely. I have this image of this woman sitting on her suitcase in the snow in a car park waiting to be picked up to be brought home to die. The two other people who were in the room, who were responsible for bed management, sat there and said, we're just doing our job. The family didn't want to take it any further. I'd have been quite happy to. But the family said, no, that's the end of it. We're walking away from this. But that is, you say palliative is a magic word. Not always.
Mr. Russell.
The degree of discrepancy, our own research, if I might just quote it very briefly. In one region, we were advised by the HSE that only 2 clients were on the waiting list. But the same area reported a massive gap between assessed need and provision. Meanwhile, in another area, there was over 600 people on a waiting list, but it was estimated that the vast majority of the assessed need was provided for. So I think it really highlights the disparity in assessments, which does lead to that reference of postcode lottery. And you do have to question that level of discrepancy and disparity can't be good and fair. There's always be a level of it within regions, within clinical assessment protocols and guidelines, but that level is of concern to us.
Senator Burke.
Yeah, just very briefly, and in fairness, thank you all for your presentations here this morning. But just one question I want to ask, and that's in relation to all of the companies, private and the community organisations and all the voluntary organisations are providing an excellent level of service to people. But I'm just wondering, is there any concerns out there in relation to where someone is offering, or it's perceived that they're offering a service and is not delivering it? And, you know, where you would have taken over the care of people where someone else was being paid to provide that care and it wasn't absolutely adequate. I'm just wondering, is that arising Does it arise very often? And, what kind of scale are we talking about?
I would say it does happen. I would say it is not, and it happens sometimes with extremely serious consequences, but I would say it's not a widespread problem. And I'd also say, because there may be an element of a discussion, this isn't a question of, private sector good and voluntary sector and public sector bad, or vice versa. There's good practice in the private sector and bad practice. There's good practice in the voluntary sector and bad practice. But you do have to be vigilant. And it's one of the mysteries, because in a situation like that where we come across it, there are very clear protocols around it. You have to report it. We never hear afterwards about what happens. But I am mindful of one case where we did report an issue in regard to an organisation. And it was, to my mind, relatively serious, but fair enough. These things can also be a one-off. Like, we've 1,000 staff going into houses. I wouldn't like to be held personally accountable for what every one of them does tomorrow at 11 o'clock, So it can sometimes be a one-off. But that company, the one thing I did see afterwards was when the HSE was making a list of people who would be charged with the most intensive, difficult, challenging cases, that company was on the list. And I did wonder to myself, but I have no way of giving any more insight than that. What I'm saying is factually correct, and I'm not saying the system is broken. It is a rare situation, but it does happen, definitely.
Thank you.
Reaction, Chairman. My guess would be where carers complain about the multiplicity of carers going into a house, that it causes difficulty, particularly for somebody with dementia, that there's a lot of different carers from an organisation, and that they're timed to task, that they have to do something very quickly and they've got to move on. That's probably, but it's as much anecdotal, I'd have to say. We haven't done any study on it.
And could I just ask one final question in relation to statutory home care, if it is introduced? Sorry, when it's introduced. There is an expectation from people that this is going to come at no cost, but it obviously is going to come at a cost to the client. I have heard people speak of it being a free service, but of course it can't be a free service. So what estimate would you have in relation to cost sharing, in other words? Because obviously the client will have to make some contribution, and the state will make a contribution. So in your estimation, when it does come in, what do you think the ratio will be, or will it depend on the amount of service required, or will it be a specific percentage?
Chair, that's an excellent question to round us up and to focus our minds going forward, because there are no easy answers to this, and genuinely, well, first of all, researching and then societally, collectively deciding on the funding model is going to be absolutely critical. And in fact, that's why it nests under Sláinte Care, because really we need to take a good, hard, adult look at how do we fund provision of care in this country. Is it going to be from general taxation? Is it going to be a blend of social insurance? And to be honest, not dodging the point, but it is early days. Our colleagues here today, Sage Advocacy, are doing sterling work on deep technical aspects of this, and we're feeding that into the department. I don't think we can answer that question today, but from my own perspective, as Age Action, as the largest representative body of ageing people in this country, we absolutely request and ask that all of the elected members in both houses today in front of us do their part to ensure that the dialogue and the societal conversation that must be held in this country about how we are going to fund this, and it's not easy, has to be adult and respectful and sustainable. Thank you.
Thank you.
I just say I don't think anybody envisages it's going to be for free. We've been on the record for a long time that we are quite willing to talk about co-payment. Now, I did mention earlier the insurance model, because it seems to me that does deserve serious consideration. But the great chance to do that in the context of the USC has possibly been lost at this stage. The fair deal model and integrating the two funds, the problem is the fair deal model is made up of, in terms of funding, is made up of 3 contributions. And if you're caring for someone at home, it really doesn't make a whole lot of sense to be taking most of their income. It doesn't make a lot of sense to be taking most of their savings. And if they're using their house as a care facility, it seems a bit rich to be taken. So it would need to be some different sort of model. And I'd agree with Audrey. I mean, it is early days in the discussion, but to be fair, nobody's suggesting it's going to be for free.
On Age Action, nor do we. I just put that on the record.
Mr. McLaughlin.
We've no indication of the cost, but there has been some research done on the intensive home care packages, which initially concentrated for people with dementia who were in residential care in hospitals. And it was very interesting to see that no night cover was sought. People who came out of hospitals were able to attend daycare centres that were already there. So our experience is carers will not abuse intensive home care. They don't want people in their houses unless they absolutely need to. And I do personally believe it will be a game changer in terms of delaying people going into residential care, which will be a significant saving to the state. If you look at the trajectory of the number of beds that's going to be needed, I do believe it's going to have a major change, but we have no information as to what the cost or funding model should be or could be.
Mr. O'Sullivan.
I think in Ireland we have an interesting relationship with taxation. There's often a discussion around wanting Scandinavian type services, yet there's not always the wider maybe societal sense that takes a level of taxation. So I think there's definitely that needs. One of the risks if people do have to pay for part of the care is maybe, and I don't have strong evidence on this, but there's maybe a greater risk of self-neglect. People will go, well, I'm not paying for it, so they mightn't get it, and it may lead to unintended consequences, and you have to balance, I suppose, to what extent the state makes a decision on that. Across Europe, there are various models. John alluded to the insurance model, probably be a preferable model, and is there a percentage direct payment, and then the rest would come later. And I think it does require political leadership across party to say, this is going to cost collectively us, but it's worth. We want high quality care, we want to value family carers and increasingly paid care workers, because that's the type of society we want to live in.
Senator Burke, have you any concluding remarks?
No.
Senator Dolan? So on behalf of the committee then, I'd like to thank you, Mr. John Dunn and Claire Duffy from Family Carers Ireland. A lot of these names are similar. Audrey Dean from Age Action Ireland. From the Home and Community Care Ireland, Mr. Joseph Musgrave and Ed Crotty, and Mr. O'Sullivan, Mr. McLaughlin and Joan Carty, who's left us from Care Alliance Ireland. Thank you very much for coming in. We may return to this topic again at a future date. So, as there's no other business, this meeting is adjourned until the 19th of December.